Good morning, everyone. Welcome to this week's special edition of Emergency Grand Rounds. We will get started in a few minutes.
Good morning. I am Colleen Carey, an emergency physician and a member of the planning committee for today's events. Thank you for attending the Mike Hodsman Legacy Lecture. This is the 7th annual lecture to honor the memory of our late colleague, Dr. Mike Hodsman. This year, it is also our great pleasure to honor the career achievements of Dr. Rob Abernethy. Next slide. Today's topic is addressing equity and diversity among our patients within the emergency department. Next slide. Dr. Mike Hodsman practiced emergency medicine for over 25 years in Calgary at Foothills Hospital and Alberta Children's Hospital. He worked exclusively night shifts for many of those years. He cared for an estimated 100,000 patients or more during his career. He was an excellent clinical teacher and an admirable lifelong learner. He was always good for a laugh with his John Lennon style glasses and a pun for every occasion. Sadly, Mike got cholangiocarcinoma and died July 23rd of 2010. We are here today to honor Mike by doing something he was very passionate about, furthering our medical knowledge. We hope you enjoy this full morning educational event on diversity, inclusion, and healthcare equity in the emergency department. Next slide. We are also pleased to honor the career achievements of Dr. Rob Abernethy. Dr. Abernethy graduated from medical school at Queen's University and then completed a 1-year rotating internship at the Holy Cross Hospital and 1 year of internal medicine residency at Foothills before returning to Queen's to complete 1 year of emergency medicine residency. This was at a time when emergency medicine residencies were few and far between. In the US and just starting at Calgary and McGill. Rob started practice as an emergency physician in Calgary in 1980. In 1983, Rob was the first person to be awarded an FRCP designation in emergency medicine, which he notes is because his surname starts with A and comes first in alphabetical order. Calgary is fortunate to have benefited from 40 years of service that Rob provided in clinical emergency medicine, administration and leadership, and in STARS. Rob stands out as one of a small handful of physicians with such a lengthy clinical career in emergency medicine across Canada. Rob's many administrative roles included, in 1980, he was Assistant Emergency Medicine Residency Program Director. 1984 to 1996, Rob was the Emergency Medicine Department Head at the Calgary General Hospital. In 1996, Rob was involved with amalgamating all Calgary Emergency Department groups into a single regional department, and then serving as the inaugural head of that department. We remain the largest group of emergency medicine physicians in Canada as a result of Rob's efforts. In the year 2000, Rob served as the Executive Medical Director for the Calgary Health Region. In 2010, Rob was the inaugural AHS Provincial EMS Medical Director. And in 1985, Rob co-founded STARS with Dr. Greg Powell. And then he subsequently served as the first medical director for STARS. Rob worked as a flight physician for over 30 years. Rob retired in the spring of 2020. Today, we would like to recognize and honor his many career contributions. The Hodsman Legacy Lecture carries special significance for Rob, since Mike Hodsman was his resident when he was early in practice, and then Mike and Rob worked together for many years. I would also like to acknowledge Rob's family, whose support and sacrifices made it possible for Rob to do what he did within our department. Rob's wife, Marg, trained as a nurse at Queen's and practiced nursing before they had their 3 children, and thereafter stayed home to care for their family. Their 3 daughters have also supported Rob's career. And when the pandemic is over, he looks forward to spending more time with them and his 2 grandchildren, being able to travel, and of course, being able to visit the hospital or some social events once in a while. So to Marg and Rob's 3 daughters, thank you for a lifetime of missed family dinners, keeping the house quiet to accommodate shift work and naps, meetings, interruptions, and picking up the slack at home. When asked what Rob misses the most since retiring, he responds, the people. He says that anything he accomplished during his career, he did, quote, with a whole bunch of other people who were really good at what they were doing, end quote. So we would like to thank Rob and his family and to honor Rob's many, many career achievements from which our department has greatly benefited. I would like to give Rob a few moments to speak to our group now. And if any audience members would like to raise their hand after Rob speaks or enter a question into the Q&A, please feel free to do so.
Well, thanks, Colleen. This is really a very great honor for me because to have a career and have my colleagues stand up and honor that career is one thing, but to also have it honored at the time of the Hodsman Lecture to me is an even greater honor. As you said, I knew Mike starting in 1980 when he was a resident. I've told this story before that Mike said a very common theme throughout my career is that the residents were always smarter than I was, and he surely was. But not only was he a brilliant man, he was a very nice man. He was a great colleague to work with. He was always in a positive frame of mind. And if you could actually figure out his puns, then you were a better off person. Sometimes they were a little difficult, but after a little thinking, you could usually get through what he was trying to say. But he was an excellent teacher. He was a excellent clinician. And above all else, he was an excellent human being. And I think we've all missed him over the last, now it's hard to believe now, it's almost 11 years. Many of the members of the department never worked with Mike, who are now working, but his legacy does remain. He was, as I say, such a great individual. As respect to my career, I am probably one of the luckiest people in the world to have had such a fulfilling career. I've enjoyed what I did for 40 years. I can't say I really ever did not enjoy what I was doing. The key things for me were that I started in emergency medicine almost at the beginning. There clearly have been emergency physicians for a few years before I started, but it was right at the beginning. So the opportunities that I saw and the things I saw developed over 40 years were absolutely amazing. And the teamwork of all the emerge docs and nurses and other emerge staff that helped build emergency medicine, particularly in Calgary, was amazing. As I said, I could not have done anything what I was involved in without the amazing support of a super group of people. And that continues if you look at today, doing this sort of a webinar with all the difficulties around it, the ability of our team members to put this all together is exceptional. So the ability to sort of be at the beginning of emergency medicine was really an amazing thing for me. And as I said, as you said in your comments, the people that I've had the privilege to work with have been phenomenal. I can't say enough about the people who have been in Calgary, are now in Calgary, and continue to build our department on a day-by-day, year-by-year basis. So those are the two things I was so lucky to be with, is the timing and the people. So I thank the committee and the department for this honoring of my career. I truly thank you for doing it for part of the Hodsman lecture series, because Mike was a very important individual to me. And with that, I'll pass it back to Colleen. I'll be a true emerge doc. I won't take up the whole half hour of what I need to speak. I think I can say what I need to say fairly quickly. So thank you, Colleen, and thank you to the committee and the department.
Well, thank you very much, Rob. And I would just like to ask if anyone would like to ask questions to Rob or raise their hand. In our, in this current pandemic, this is, it's our only way to interact with Rob since he's retired. So from Ian Wishart, he says, "It was an honor and privilege to work with you, Rob. Thank you. How do you explain the energy and enthusiasm you have demonstrated throughout your career?" Yeah, Rob, can you give us some tips as to how you stay fresh, enthusiastic, and energetic through such a long and accomplished career?
Well, thanks to Ian. Ian has always been a great colleague, and I thank him for his comment. I think to maintain the energy was you feed off the people you were working with. When you go into a committee room to try and solve a problem, and you've got a number of people there very willing to participate in that and be eager to solve the problem, it was easy to have the energy. I will also again thank my wife and family for allowing me sort of the time to be rested, to be energized, because their support at home was amazing, and the ability to allow me to do what I needed to do. But again, it was the people. People allowed the energy to flow. And I'll give the department even better credit. Years and years ago, when I started in administration, I to some argument with some people, really pushed that if I was going to do administrative work for the department, my schedule needed to have a little bit of adjustability to it so that I could stay alive. And the department, right from the very beginning at the Calgary General in '84, was very accommodating to allow me to work a very significant clinical load as well as doing my admin load. And they did that by allowing me to have an adjustable schedule so that I didn't have to come off a night shift and then spend 10 hours at meetings. So that also helped a great deal. And I think the department has continued to do that for its administrative people and should continue to do that.
Okay, and then Dr. Wishart has a follow-up question, Rob. Did your golf game ever get better?
Let's just say, like many things in life, it has its ups and downs, Ian. But I'm truly hoping that it starts to get a little bit better this summer.
And Tona Laritz says, Rob, you were always a great pleasure to work with. Thank you for years of dedication. Every time I see someone with their ankles crossed, I think Abernethy sign. Lester Mercure says, Rob, it has been an honor to work with you. It just struck me, particularly with this lecture today, that you were also the first to embrace diversity in the department by hiring me, a South African trained doctor.
Well, Lester has to remember that the hiring committee forced me to do that.
Darren Sandbeck says, it was such a great pleasure to work with Rob in the early days of building our provincial EMS system. His sage wisdom and advice, and sometimes outright direction, is still felt in our system today. Thank you for your service, Rob.
Thanks, Darren. Appreciate that.
Paul Huang from Vancouver says, congrats and thank you for being my teacher along with Mike during my residency. He gave me the lifelong love of puns, and you reminded me of someone who cleaned a temple when you took over CGH. What advice would you give to new EPs in this world?
Well, maybe I should stop giving advice to people, but the new EPs coming in, I think you just have to look at what is available for emergency physicians as far as a career, the multitude of things you can become involved with, the strength we now have with our consultants, even though at times it seems difficult, but I think that emergency medicine is extremely well respected by people. So the diversity of what you're able to do, the respect that our specialty has, I think leads to a very strong career for people. The other thing that EP physicians need to do is make sure they truly live a balanced life. So have that home life, have that physical life, have that intellectual life outside of emergency medicine that makes you a good person. And if you do follow those things, you'll have a great career.
Another comment from Sean Dowling. Aber, your nickname Aber, thank you for your mentorship and perspective. You have such a balanced perspective and your wisdom is missed. I'll never forget that canthotomy we did together. And that was when I was in my residency year. I remember seeing Sean Dowling with a CGEM journal article and walking through the canthotomy in the trauma bay with Rob Abernethy.
Well, that was an excellent example of what I commented about. The residents were always smarter than I was after Mike Hodsman. Sean Dowling continued that. I remember that case, and we saw this patient, we looked at this eye, and I wasn't sure what to do with it. I'd never seen it. And Sean, of course, came up with the literature on it and the plan and said, Doc, I think we need to do this. And he was so convinced and organized. I said, well, Sean, let's go ahead and do it. And he did it. So I've never done one, but I have assisted in doing one when Dr. Dowling did it.
That's great. And Aaron Bugby says, thank you for your dedication to our department. It was always a pleasure to work together. Andre Mahalchuk says, Rob, thanks. And only 9 years to go to catch you. Love your humor.
You're going to enjoy it, Andre.
I think, though, ideally, you don't want to retire in the middle of a pandemic because it's quite boring, right, Rob?
Well, yeah, it's, to say the least, has been a bit quiet. I saw Mike Betzner on the golf course. Thanks for inviting me to golf a few times in the summer. But yeah, because of the pandemic, I've not been able to even wander back to the department to say hello to people. So it's been a bit quiet for the last 9 months, but hopefully things are going to start opening up and we can all get back to talking to each other face to face instead of on a computer.
Yeah. And Mike Betzner says, Rob, thanks for always being a great positive role model for all that worked with you and for fostering one of the strongest emergency departments in the country. I don't think I ever saw you have a bad day, and we could all learn from your glass half full attitude. Looking forward to hitting the links with you this summer.
Well, thanks to Mike. And
Jill Nation says, hello, Rob.
Jill and I were interns together at the Holy Cross, and she's a great person. Great.
We have 127 people with us right now. So that's how many people wanted to come out and see you, Rob, and honor your career. We have a few more minutes if anyone else wants to add in some comments.
I think they more wanted to come and hear the lecture and hear a little bit about me maybe, but the lecture I think is more important.
Alexis Majot says, Rob, you were always a pleasure to work with. You brought a smile to my face every time I worked with you. It was your insight to have the nurses on the helicopter 24/7 back in 1989.
Thanks, Alexis.
And Jennifer Smith says, as a nurse, I appreciated your inclusion of your nursing colleagues in discussions and willingness to teach. Thank you.
Thanks to Jennifer. That's one thing I probably should have said to how to be a successful emergency physician is to make sure that the nursing staff and the emerge staff are on your side. Because if they aren't, you're going to have a very long and difficult career or a very short career.
Yeah. And Ping Chen says, Rob, I am grateful to you for your guidance all the way back from when I was an undergraduate student, all the way coming through and joining as staff in Calgary. I'm pretty sure you're responsible for turning me and a whole bunch of our department onto emergency medicine. You are a role model, and I hope to be able to emulate all the valuable lessons you've taught me. Best wishes to you and your family.
Well, thanks to Ping. And Ping, again, is another one that I guess saw the Hodsman rule of being smarter than their preceptor. So well done, Ping.
Excellent. So thank you so much to everyone for honoring Rob, and also for continuing to honor Mike Hodsman. That about wraps up our time. Oh, we have one more comment from Janice Deckers. Aber, they say illegible handwriting is a sign of a brilliant mind. I miss your brilliance here at Peter Lougheed.
I was waiting for somebody to say something about that. And look, I haven't taken up calligraphy in retirement yet. So.
No, well, there's a hobby you can get. All right. So I think we're pretty much ready to turn things over to our resident, Dr. Bobby Johnson. Welcome, Bobby.
Thanks, guys. Just reflecting on us as we all sit in our unique and beautiful spaces in this beautiful land that we have, Calgary. And I'd like to draw your attention a little bit further south, just north of the border, to the Blackfoot Crossing here, which is an important land historically to Indigenous people. And there's a beautiful site here which commemorates the signing of the Treaty 7 in 1877. And I would encourage people who are curious to know a bit more about the history of this land and the original caretakers to go here. I think they're closed right now for renovations. But I've been here and gone through a tour, and I thought that it was quite illuminating, and I would encourage anybody who's curious to turn their attention there. Next slide, please. Oh, sorry, just the next slide, please. Going back north to Calgary, we currently sit at this amazing intersection between the raging Bow River, which comes to us from the mountains, glacier runoff, and the lazy Elbow River that intersects on this land that's Calgary, where we're gathered today, which also has historical importance to the Indigenous communities that called Calgary and the outlying lands and structures their home. It was an important gathering place for Indigenous communities and continues to have contemporary importance to the communities that I'll mention shortly. If we could go to the next slide. So I think it's important to acknowledge that this land has a history that is sometimes not discussed and talked about. And so I think we'd like to acknowledge the authentic history of this land and the original caretakers of this land. In doing so, we like to draw attention to the fact that we gather today in the act of creating and passing on knowledge on the traditional and contemporary territories of the Blackfoot Confederacy, which include the Siksika, the Kainai, the Piikani, as well as the Tsuut'ina and the Stoney Nakoda nations, in addition to the Métis Nation, the Region 3, as well as all the people that make their homes, that play, that gather and live on the Treaty 7 region of Southern Alberta. Next slide, please. I think today, as we sit here and we hear from our speakers that are dedicated in their own rights to evolving the understanding of diversity, inclusion, and equity in their various domains, that what we're doing is we're listening to threads that overall can be woven into the larger fabric or tapestry of the overlying structures of diversity, inclusion, and equity as they relate to healthcare, but also really to society in general. I think it goes without saying that what we're about to embark on today is an understanding that we're going to hear about the tip of, I think, the larger iceberg that sits beneath the water. For many of us that come here today to listen to this, we'll be well versed in this and we'll have heard similar stories and we'll be able to relate to this. You know, on the other end of the spectrum, I think there are those of us that are here today that might not have thought about this closely, that might not relate to the stories that they're about to hear, or really understand in a greater essence what it is that we're here to talk about. And then I guess for many of us, we sit in the middle where we have a lot to learn, but also a lot to offer. And so I think it's important to recognize that we're going to hear some of the stories and start recognizing some of the importance of issues surrounding diversity, equity, and inclusion. But there's a lot more underneath the surface. And I think if we're curious and if we pay attention, there's a lot to learn just by engaging in the world around us. We can go to the next slide. So the timeline this morning, we've already introduced the legacy that is Dr. Mike Hodsman, and we've heard from Dr. Rob Abernathy and enjoyed the comments surrounding the support and the love for him in his retirement. Going forward, we're going to hear from the following speakers. So Dr. Shukaluk, Dr. Dhaliwal. We'll have a little break at around 10 o'clock for coffee and refreshment. and then we'll hear from Patrick McLean and Bonnie Healy. We'll have another break, and then we'll progress forward, and we'll hear from our esteemed keynote speaker, Dr. Esther Chu, and then have an opportunity to hear some closing remarks and to reflect for ourselves. Sorry, next slide. So I'm pretty excited to introduce Dr. Shukulik. I recall him as a resident when I was working in the ICU as a nurse, and I always thought that he had the most genuine and wonderful presence at the bedside. He now, in his role as an attending, continues as the clinical assistant professor in the departments of medicine and community health sciences, the medical informatics lead with Connect Care, in addition to being the FMC Department of Medicine site lead. His clinical and academic work focuses on health informatics and system interventions for the prevention and management of persons with or at risk of HIV and STIs, with additional interests in sexual and gender minority health. Outside of medicine, Kaylee is a board member and research committee chair for the SHARP Foundation, which provides harm reduction and support services for persons living with or most at risk of HIV infection in Calgary. SHARP has championed work that helped formulate the Aging with Pride document and is actively creating training modules for providers who work with the LGBTQ2S+ elders. I'll now turn it over to Dr. Shukulik so that he can describe his work in more detail.
Thanks, Bobby. Hi, everyone. It's Kaylee Shuklak. I apologize for my lack of video today. I just wanted to talk, I got asked today to talk about LGBTQ2S+ medicine, or I'm going to refer to it more as queer medicine, is sometimes a common vernacular. We'll go into this, but I first just wanted to, next slide. I'll give some kind of disclosures and experiences. So yes, involved in some charitable organizations, as well as some work related to queer medicine and equity, diversity, inclusion initiatives, and also some work through pharmaceutical and for-profit disclosures, as well as experiences. A lot of this has kind of shaped who I am as a person, and in particular, I'm aware of my privilege as a white man and a cisgendered man, but as a non-visible minority or a gay man, there's certain things you experience in life or go through, and that's shaped who I am as a person, who I am as a provider, and I think it's just instrumental to how I kind of carry myself. So, but thank you for your kind words, Bobby. Next slide. So objectives today, I do want to discuss, who is who in the queer community, and briefly explore queer patient and provider perspectives in health. Talk a bit about important queer resources, particularly those relevant here in Calgary, but more widely available as well, and some guiding principles in discussions or interactions with queer persons. Next slide. So my outline will kind of follow that as well. So next slide. So we've all, or most of us, I'm sure, have heard of, what the LGBTQ2S+ acronym stands for, with lesbian, gay, bisexual, transgender, queer, questioning, and two-spirited individuals. Of course, that plus is there because the community is much more diverse. This is the sexual and gender diverse spectrum. Next slide. So we do hear internationally in communities or nations that have less Indigenous populations or don't have this context of a two-spirited individual, they use the LGBTQIA+ acronym, which includes intersection asexual individuals. Next slide. But of course, there's pansexual, which I always get questioned about what that means. And it is a very personal definition. So I would encourage individuals to, if you're not familiar with any one of these specific terms, feel free to Google them. And I'm actually okay with my slides being made available as everything's referenced or my own thoughts. But there's also gender fluid individuals, non-binary, androgynous, and many others that would themselves identify within this queer continuum. Next slide. So I put this up here just for awareness around the gender unicorn. And this is just to impart the difference between these variety of things. There is gender identity, which is how someone themselves identifies. And this is not a preference. You know, you see in the media now preferred pronouns. Well, they're not preferred, they are their pronouns. So I do like to just make that clarification. There's gender expression or presentation. And this is very societally based, feminine, masculine, other, and each individual person is gonna define themselves uniquely. Your sex assigned at birth. And importantly, this is potentially chromosomal, but actually not. It is more what your phenotype or your appearance is, and what the doctor who is there, who when you are born kind of decides to write on your birth certificate. And then there's your sexual attraction, which can be to any and all of the above gender identities and expressions, as well as romantic attraction. And those two do not have to align either. Next slide. Now, I'll just briefly touch on, there's a couple points here about estimates of, you know, what the queer community represents in terms of total population. Suffice it to say, there's many estimates. They're all different. No one really knows. This changes over time, how people identify or people how express themselves. This also their current or future romantic and sexual expressions or interests as well. Just looking at, you know, what populations are being sampled in these estimates. Is it urban? Is it rural? Is it US? Is it Canada? Is it, you know, Ugandan? Like it really does matter quite a bit. So we're not sure, but suffice it to say, it's somewhere in the range of 1 to, my guess is probably in the 6% range of the population. So it is not small in terms of who kind of would fall into this spectrum of or community. Next slide. And I'd be remiss to not discuss intersectionality as a part of this. Next slide. Certainly, for the purposes of what I'm speaking specifically on today, we're talking about sexuality, we're talking about gender, but there is so much more to privilege or oppression and what it defines people. Gender is a more outward or obvious expression or identifiable privilege, whereas sexuality is what we sometimes refer to as invisible. And so more internal, and I'll explain a little bit more about that in a second, but there are, you know, whether your race, ethnicity, religiosity, a variety, able-bodied variety of things come into what makes a person and how they experience the world around them. Next slide. And that's actually formed the transition or the evolution of the pride flag. And I'm not sure if everyone's seen this here by Mr. Xavier. He made this new pride flag kind of in the wake of the Black Lives Matter movement within the death of George Floyd and other tragic events in the United States and actually around the world. And this is a representation of the original pride flag with its rainbow and the black and brown stripes to recognize that our community is very diverse, as well as the blue, the pink, and the white to represent our trans community that's been so instrumental in the rights that have been hard won by the queer community. Next slide. So I'll talk a little bit about perspectives. Next slide. First, I'm going to talk a little bit about the patient perspective, and I do want to touch here on kind of interpersonal discrimination that is experienced, and this is outward, this is, you know, direct. It's also indirect, and it's also institutional. You know, microaggressions are those small little things that maybe are not outward or direct, but they do have a profound effect on individuals, such as heteronormativity or heterosexism. And that's what I mean is the normalization or assumptions that are made. I can't count the number of times that people see my wedding ring and ask what my wife's name is. And it's small, but it does make you feel less a part of the world or less a part of the community. And that goes with assumptions. Certainly slurs do happen. I've experienced them as a patient, as a provider. Sexual harassment is common amongst the queer community, particularly those who are transgender or non-binary. And again, violence, which outwardly, I'm not sure those who are aware, but in Calgary over the summer, there was a single weekend where there were 3 separate violent episodes or community events that were directly related to either transgender or sexual minority individuals. So, and the important part in this is 1 in 6 persons in queer community will absolutely avoid healthcare due to fear of discrimination within the system itself, which tells me that there is still a problem. Next slide. Now, I can talk about, I didn't touch on too much my own perspective in that patient, from a queer individual's perspective, but I certainly have myself, younger and more recently, been subject to discrimination from individuals, direct and indirect. But it's also there as a provider, and I got asked to write this article for Vital Signs back in 2019, but what it was like being out in medicine. And I, had the fortune of locuming during my clinical fellowship in sexual health in rural Alberta, and that was an eye-opening experience for so many reasons, and being new staff, but also in terms of being actually cautioned by colleagues in those locations. Don't disclose that you have a husband, don't disclose that you're gay, don't wear a rainbow flag on your stethoscope or your ID badge, because you will hear about it. And then, saying, okay, well, I'll do it anyway. And then I do hear about it. And I do have homophobic slurs uttered at me by patients. And not just by patients, but actually by other healthcare providers. And I wish I could say that was geographically limited, but I've actually experienced it in the very hospital that I work at in Calgary. So there is still a way to go in this perspective. And AHS is doing all that it can in this regard, for queer individuals, but also for other persons who experience oppression or have a lack of equity. But there's still room to move on this. Next slide. And so why does all this matter? Of course, discrimination is something we should all worry about, but it also does reflect into health outcomes of queer individuals. Next slide. There was a standing report to the Standing Committee on Health nationally that looked at this, and they recognized disparities around mental health and substance use, cancer, cardiovascular disease, hematologic disease, and sexual health in the queer community as opposed to the non-queer or heterosexual cisgendered community. And what I'll say about this is there's evidence to suggest all these things, but it is not near the same quality of evidence we see in so many other populations. And part of that is due to sampling. People don't get asked these questions, or, how do you identify, or what is your sexual orientation? So perhaps we don't know the full picture, and I'd love to say there aren't disparities, but unfortunately in my practice area, I can tell you that I think that the small amount of evidence we have is right. And so not only are people themselves experiencing discrimination, which leads to things like mental health and substance use, but their physical health is also being compromised. Next slide. So providing all this information about why it matters, but how do you as individuals perhaps have better interactions with LGBTQ2S plus patients? How do you overcome this? How do you make people feel comfortable? How do you avoid that, or kind of help that 1 in 6 person who perhaps is fearful, and to be honest is most likely to present to the emergency department because they're going to present sick or unwell or have nowhere else to go. So the group here that's listening to this is, I think, of particular importance, and I think I can't say I've had any bad interactions with any of my Emerge colleagues. I think everyone I interact with is so open and honest, but perhaps there still is room for improvement. So next slide. I do want to talk about just general principles. First is I think the first foremost is to be curious, and we generally are as physicians. We all play a little bit of detective work. We ask people questions. We're trying to figure out what's wrong with them and help them, but be curious, but also avoid assumptions. So what are someone's pronouns? What name do they go by? I can't count the number of times that the chart is wrong for patients, particularly those that are not cisgendered, as well as in terms of previous documentation or lack of documentation around their sexual orientation or their romantic habits. So be willing to explain your thought process. If I can give a quick example here, I'm a PrEP provider, so HIV pre-exposure prophylaxis, and I recently had a conversation with a transgender male patient who was on hormones but intermittently still having bleeds, and they were actually, and I put my foot in my mouth too with at times, but I explained that we needed to do a pregnancy test, and the patient was quite taken aback and offended, and I explained that you still have ovaries and a uterus and you are intermittently bleeding. So if you are engaging in vaginal sex, which they were, you can technically still get pregnant. That, your use of testosterone does not eliminate that. And they were actually unaware of that as well. But it was me being able to take the time and explain process. And I understand the emerge is a busy place and all clinical encounters often are, but that willingness to explain it actually, I think, repaired, and I've seen that patient or any sort of relationship or maintained it. And I've seen that patient since, and they were actually so thankful to know that, because they didn't know that they could still technically get pregnant before any sort of operative procedure to remove their estrogen producing organs. So, and the other thing is to be willing to apologize. And in that example I gave, I did apologize for perhaps making assumptions, which we all will still do at times, even though I said don't do that, right? It's to be willing to say, I'm sorry, I didn't explain myself well enough. Let me tell you what I'm thinking about. And the last is that you might uncover trauma with these patients, as they've been witness to discrimination inside the health system, outside the health system, from people they love, and so that trauma-informed care that I know so many emergency room physicians are aware of and practice is so important. Next slide. So in terms of interactions, and what I might suggest is, simple questions is, because these are all not making assumptions, is what do you go by? I didn't put this in here, but I when I walk into a room, I don't say Mr. or Mrs. to patients. I actually just use their first and last name as it's written in the chart, and that's the best I have. But if they correct me, I say, okay, thank you. I will make sure, or I'll make note of that so that we can correct it in the chart. Asking what your pronouns are, and that's that part of not using the Mr. or Mrs. when I walk into a room, because I don't know, and I certainly have a very specific practice pattern doing a lot of sexual health and seeing some subspecialty transgender medicine issues or gender affirming care issues, and so it's perhaps more me than others, but nevertheless. And then when you're asking persons about relevant personal or sexual history is, can I ask you some personal questions or some more personal questions if you're getting more into it? Questions like, are you in a relationship, rather than, do you have a boyfriend or girlfriend, and are you having sex, and who are you having sex with, are very non-assumptive questions. They let the patient tell you, and you'd be surprised how open and honest people are, because they are worried about their health if they're sitting in front of you, and so they're going to tell you each and everything that they think they need. And if you need more information, just explain why. Again, it's that explain yourself and be curious. Next slide. So wrapping up a little bit in terms of kind of overall takeaway points, queer or LGBTQ2S plus persons still face discrimination in the healthcare system and outside of it. And this can result in worse health outcomes, and each individual interaction is an opportunity to make a difference in that. And your single interactions can certainly make it better. Unfortunately, they can also make it worse. And I think, we are limited particularly in the emergency room. This is often the first time you're meeting a patient, and in sexual health, it's often the first time that I meet a patient, or I have those first interactions too, and all those things that I said as standing general principles will, I think, help build the relationships with individuals who have suffered trauma, who have suffered adversity or oppression for various personal attributes on their own, and so if nothing else, these are, I think, two really important takeaway points. Next slide. Just to, as it was mentioned by Bobby, I had a hand in drafting this guideline that's built out for health service organizations in caring for LGBTQ2S older adults. And we're in the secondary phase of actually developing training and resources for healthcare providers around these interactions, specifically tailored to care of older adults, but I think in general or broad strokes applicable to the entire population and actually outside of the LGBTQ2S community, because this kind of compassionate care and practice that, while it takes time, I think can have pretty profound impacts, is applicable to all individuals who experience adversity. Next slide. And so just some good resources. So there's lots of stuff on My Learning link through Alberta Health Services. Alberta Health Services has the Sexual Orientation, Gender Identity, and Gender Expression Working Group, or SOGI. And there's lots of references on their website. And then there's lots of community resources in Calgary, Center for Sexuality, Outlink, a variety of things. And there are certain more guidelines or resources being made available. Next slide. And just some references, and next slide. And this is just out of a program that runs out of Toronto, but just understanding, and this is targeted towards LGBT older adults, but still nonetheless applicable is, you know, if we celebrate and give everyone a home and respect, then certainly we're going to see the best things occur for our patients. Thank you.
If anybody has any questions for Dr. Shukalak, we'd be really open to having, we have a few minutes to allow him to answer questions if you want to post those.
Well, thank you again, everyone, and feel free to you know, look into any of those resources that I had mentioned, or check out the Alberta Health Services SOGI website. And thank you so much for your time. And maybe it was a bit heavy to start. I apologize for that, but it's definitely a passion area of mine, and yeah, I'm happy if you want to reach out to me with any further questions independently, because sometimes talking about this area can be a bit personal or not so much. Oh, I see a question from Scott about the PrEP program. So PrEP in Alberta, so HIV pre-exposure prophylaxis is a single tablet regimen that is approved by the Alberta government and covered. So this is brand name Truvada. There is generics available for those who qualify, which really is, I think, any and all that or would be most at risk for HIV. So they would see a provider. You need some baseline screening, including HIV, hepatitis B and C, Hep A immunity status, and then some creatinine and CBC monitoring. There's a list of providers available online. If any provider wanted to be a PrEP prescriber, they can do the quick course to be approved, as you need that to gain your patients free access through the Alberta government. And it's a once daily pill, at least the on-label or labeled use of it is a once daily pill that has you know, near 100% efficacy and effectiveness, actually, in terms of preventing new HIV infection. So there are some new pharmaceuticals coming soon, but not quite yet approved in Canada. Nevertheless, it does require longitudinal care as there is monitoring ongoing. So someone should be getting STI and HIV screening every 3 months when they're on PrEP, because obviously they're at risk for acquisition of HIV. Adherence can create issues with its effectiveness, and then STIs do occur, quite higher rates among this community as well, so, or this population of patients. So if you're interested, there is a AHS website actually on this with the guidelines that I was involved in, and there's clinics all throughout the city that and province that do offer this, as well as online access too. I'm just looking at Haley's talk about sexual organs of transgender. So how do you in the trans or in the transgender population? I think again this comes down to the being curious now. So if someone identifies themselves or that's listed on their chart that they are transgender, and then being inquisitive about, okay, so what medication, it's as simple as the regular history that you're going to take. What medications have you had? What surgeries have you had? And in asking those very generic questions, you're not specifically interrogating them on their hormone regimens. Because if you ask about your transgender status and then immediately say what hormones are you taking, are you pre or post-op, it's very it's almost too inquisitive and too directed, whereas I as a general internist, I do see transgender patients with complex medical issues, and I actually get a lot of the question is this because they're transgender is somewhere in the question, and I'll be honest, almost always my answer is no, unless it's a VTE for someone who's on estrogen, and then it's a weight risk benefit analysis. But if you're just generic in what medications are you taking, okay, they're on hormones, they're not on hormones, what surgeries have you had, and if they say, oh, I had a hysterectomy or I had a nephrectomy, then that kind of information is going to come out, and you're keeping it generic and relevant to their overall health, as opposed to digging down into one specific issue that they're going to be in, probably for good reason, sensitive about from prior experiences.
Just a couple more questions here. So Mandeep Strand says, thank you for that presentation. What would you say is one addition to our practice that we can add to better serve our queer patients?
I think that's a hard. I just know exactly what what part of your practice, if you're thinking your individual patient interactions. I mean, there's actually been research into signage versus direct statements versus expression of interest, and of course the directed statements and expression of interest do way better with patients, but it's not difficult to. I have a rainbow sticker on my ID badge and on my stethoscope, and it's subtle, but I've actually had a patient who just commented on it and then divulged to me stress around her transgender son and issues it's caused in her marriage, and what I'm managing her blood pressure, and obviously stress is a part of that management, and so is I don't know that she would have disclosed all of that to me without some of those kind of less or more subtle cues. But that's a difficult question, Mendy, but even the little things I think matter, and I'm saying that actually from a patient perspective too.
Jennifer Smith says, thank you for your narratives and your resources, and addresses that there's a lot of work needing to happen to improve the experiences of queer patients, and was inquiring specifically to an ED specific group. Is there anything that's going on in terms of improving care for queer people in the EDs with an ED specific group? Either to you, Dr. Shubelek, if you know anything about that, or maybe the broader audience.
I was actually before this trying to look up some specific literature, and a lot of it, you know, it's actually sparse in general. This is a growing body of work, but it's still very small. Even in the U.S., it's a much larger population than us. But what I did find in the U.S. is you know, of course, those indirect things, like I just mentioned for Mendy, the signage can matter, but I think part of that too is also you know, things actually just like this. It's education and awareness among, you know, people might not have understood that the queer community actually has worse health outcomes, both mental health, substance use, and physical ailments. And I think awareness of that may perhaps creates a sensitivity to understanding the need to recognize these things about, you know, charting, about how you interact with patients, and, you know, presumptive versus curious open language, and those types of things. So it's difficult, and there isn't a lot of evidence, and I actually make a habit of not being an ED patient myself, so I can't actually give much anecdotal experience there either.
Thank you. Dr. Jennifer Putty, she writes, you know, it's quite frustrating for me and difficult for the patient when the eMERGE chart has only the patient's legal name and not the preferred name or identifying pronouns. Given that you're doing work with Connect Care, do you know if that's going to address the issue, if that's going to be enhanced in some way for better interfaces with the queer community?
Yeah, so SOGI, the sexual orientation, gender identity, and gender expression interest or advocacy group within AHS had a huge hand in developing these parts of Connect Care. And so yes, it is much better. Is the system perfect? No, and I don't think any one system will be, but it is better in terms of reflecting, you know, a patient's name as they want to be referred to, rather than what's legally on their birth certificate if it's not yet been changed, as well as their gender identity. So those things are more easily changed within Connect Care, and you know, because it actually has functionality in it to reflect the legal record and then the patient's stated record. So yes, I might, you know, if they state that to you as the emergency physician, can you make the changes? I don't know about that. I don't think so, but certainly it's an easier fix for even the unit clerk at the front who has some of the scheduling access. So
awesome. And I think we have just one last question, and that's coming from Dr. Colleen Carey. And she's curious to know, with regards to patients that are presenting to the emergency department that are looking for information regarding PrEP, how we go about making a referral to the PrEP program, or if there's specific areas that we can address.
So referring specifically to PrEP programs, so you know, if you provide, patients can actually look up the list of providers who have taken the course, and so they can find one closest to them. You just actually have to go to, if you Google AHS HIV PrEP, you'll get that list of physicians. Certainly there is the Sexual Reproductive Health Center at Shumir. Yes, they do PrEP. There's also online versions patients can search for too. So, but there's clinics throughout. If they're from rural areas, it can be a bit more difficult to gain access, but in an urban setting, it's as simple as Googling on the AHS website, and actually as one of the providers, we have to agree to put our like office phone number and everything on there. So it's quite easy to gain access through that way.
Thank you. I think that's awesome and very helpful. And I think that's it for questions at this point. So thank you again for your time and for participating in this. That was really fantastic and amazing. And now I will draw your attention to Dr. Eddie Lang, who will introduce Dr. Dhaliwal.
Thank you, everyone.
Good morning, everybody. I'm Eddie Lang. I'm the department head for emergency medicine here in Calgary, and I have the distinct honor of introducing our next speaker. In the interest, not to steal his thunder, I'm going to be really brief and introduce Dr. Dhaliwal in a minute. Firstly, I just wanted to let you know that I'm a proud member of the Hodsman Planning Committee since its inception, currently under the excellent chair and leadership of Marcy Veach, and I'm sure we'll be hearing more about the committee later. But first, let me tell you about your next speaker. Dr. Dhaliwal, known to many of you, known as Harry, has quite an exceptional career that he's bringing forward to us this morning. Graduated medical school from Armed Forces Medical College in India, and went on to a career in neurology with critical care fellowship at Yale University, worked as a clinical assistant at Foothills, and is now currently working in Fraser Health on the neurology service. One of the reasons that we've asked, of course, Dr. Dhaliwal to come and speak to us is related to an accident he sustained and a continued disability that he lives with, related to a car accident that occurred in his final year of medical school. And it's a real pleasure for Dr. Dhaliwal to be able to join us this morning. And I'm going to gladly turn over the mic to him for his presentation. Thank you.
Good morning, everyone. My name is Dr. Harry Dhaliwal, and I'm working as a neurologist at Fraser Health in BC. 3 months ago, I had a very pure cerebral stroke, which affected my left hand and my speech. So I'll be focusing on trying to speak slowly, but in case I'm muffling my words, do let me know. So my road to becoming a physician has been a long and arduous one with lots of fair share of bumps along the way. I'm both a physician and have been a patient many times, as many of you know, which gives me both a unique lens on the biases among physicians, including myself. I'm here to tell you pieces of my story, which have fundamentally changed my perception on healthcare disparity, especially in regards to disability and healthcare. Now, I'll talk about my first experience as a disabled physician in India. I started my career, my medical education in Armed Forces Medical College, as Dr. Lang mentioned it. And when I was one of the cool kids, I was like a jock. In my fourth year of medical studies, I was in a motorcycle accident with my parents in Kashmir and had a spinal cord injury. After coming out of the hospital, I wanted to resume my studies, but I faced some pushback from some of my professors and some even encouraging me to pursue art instead. And I am horrible at art. Fortunately, he found a strong advocate for me, my dean. He was a major general in the army, and he said, Harry, do you want to finish your medical studies? And I said, yes, I do want to, sir. And he said, then go do it. And he sent a memo out to all the departments saying that, okay, they should give me all the help they could, if possible. And I finished my medical education at the medical school. Like, my medical school is built on an old site of British Army barracks, and that's what we were using for wards for my medical school. So they were all spread out, and there were no elevators, a lot of stairs, like no sidewalks. So my colleagues would carry me up and down the stairs for the next 1 year for the last year of my medical school. So due to the support of my college and my dean, I was able to finish my medical school. Now finding an No, I had difficulty finding a hospital for doing internship. I thought if I applied to a modern hospital in India with elevators, I would be able to finish my internship with less access problems. But again, just being in a modern hospital doesn't mean your mindset will also be open or modern. And I had difficulty finding a hospital for an internship in India. Eventually, I found one, but it was not an accessible hospital. And I had to hire 2 guys to carry me up and down the wards every day for the next 1 year. So I'll be forever be thankful to my colleagues and my team who were very supportive of me and helped me finish my medical education in India. And now I'll talk about my experience in Canada. I moved to Canada in 2003, and that's when I felt that I left a discrimination back home. But when I came to Canada, I did feel some discrimination from my international medical graduate colleagues of mine. Many of them thought I would not be able to get into a program in Canada. So I had difficulty finding a steady group of international medical graduates. And they felt I will be more of a liability. Oh, an IMG has to getting a position in Canada would be a difficult one. Or you being disabled, it'll be even more difficult. You'll be a liability for a group. So I could never find a group to study in. But that was a good thing. But perhaps I should even thank them for fueling the fire in me. I did most of my preparation alone and eventually became the first IMG in a wheelchair to get a neurology resident position in Canada. Unlike my wife, I can never self-advocate for myself. I always feel if I advocate for myself, then people might construe that as, oh, he's cribbing all the time, oh, he is complaining all the time. So I would never do that. But fortunately, my program director at that time, Dr. Lara Cook, as many of you know her, she was very supportive throughout my training program. She tried to do everything she could possibly do to make sure I had a level playing ground with my peers. And for example, I did not have accessible call room in Foothills Hospital. The washrooms were very narrow. I couldn't even get my wheelchair to the washroom. And I was using the ER washroom. And then Dr. Cook, right for 1 year, she tried emailing multiple people, made multiple phone calls, but she hit a stone wall. And after 1 year, she said, okay, I'm going to try one last time. And she used two magic words, human rights. And that's it. I had a team next day in the morning in the basement in the Foothills Hospital with a team from the builder, a team from the university, the health region, and the hospital. And within 1 month, the call room was made accessible. And that's the same call room I shared with the ER physicians for the next 4 years of my training program. And Dr. Cook has helped me a lot, and like she was a big advocate for me. She had helped me a lot during my journey as a resident. She always, advocated for me for various things, including having accessible tables in a resident room in the library. She also got me extra funding for traveling to conferences with the caregiver. That really helped me put it par with my peers. So uh, even today, I'm not able to advocate for myself, and I'm also still looking for another Dr. Lara Cook here in BC who could be in my corner. I'm now talking about my experience as a disabled patient in Canada. Every time I got admitted to the hospital, I was lucky enough that I would have my colleagues or my friends or people known to me would care for me in the hospital as a patient. So I did get extra care, but not everybody is that privileged. In 2016, I was on top of the world. I was about to finish my residency. I got a fellowship at London Health Science Center in epilepsy. I was doing very well, and then suddenly what happened was I had multiple bed sores, and one of them got really infected, and I developed the hip osteomyelitis, and I had to be hospitalized for 5 months. So I was not able to give my exam for the Royal College that year. I missed the exam, and because I couldn't give the exam, I could not join the fellowship the next year. So everything came crumbling down for me. I was very depressed. I hit rock bottom, and I was very silent, became very annoying to the nurses and doctors in the hospital. But the nurses and doctors got me. They understood what I was going through. And while I was in the hospital, I got an interview call from Yale University for a fellowship for 2 years at Yale University. So now here I've been lying in the bed for almost 2 months. I could hardly sit up for 10 minutes at any given time, and I would start throwing up, just lying flat on the bed for 2 months, like on a sand bed. And how would I give a 2 hour phone interview? That was impossible for me. But the nurses, the doctors, they got me ready. They had a plan. They took away all the posters in the room on the wall, made it look like an office. They got me sitting on the chair. I had two IV lines running on me. They gave me Gravol, Maxeron to get the nausea under control. They dressed me up for the interview with a coat, shirt, and tie. I had no pants on for the formal interview. I was totally commando for my interview. It was Ivy League school, and that's because I had a Foley in, I had a vacuum pump on, I had massive bandages on my hip and my sacrum. So I could put the pants on. But I did get my interview for 2 hours to the Ivy League school without pants on, fully commando, and I did, to the surprise of my wife and her disappointment, I did get the fellowship at Yale. So very thankful to all the nurses and doctors were there to support me throughout the interview process. They were my cheerleaders at a time when I was in a very dark space. In conclusion, I would say that I've experienced discrimination, prejudice, and assumptions that are extremely wrong. I've gone out of my way to prove my abilities and an independent, sometimes at my own peril, resulting in illnesses and tons of bed sores. I may not advocate for myself every time, but I do feel if you could or people like you could stand up for us, for people who can advocate for themselves. That would really help us. I do feel that it was, this does not occur to me that none of it was weakness. It was all strength and its truest form. And for anyone who continues on the face of adversity is a definition of true strength of character. Thank you. I'd like to mention one more achievement I had in Fort Elizabeth. Really, I was doing a rotation, I think so, in the ICU, and I had to do a center line and one art line to pass the rotation. But during one of my rotations, one of the attendings that week would pass away all my center lines and art lines to a different resident. And he was not even considering me for doing these procedures. But I had one of the another next week. I had a Dr. Andrew Kirkpatrick came in, and he said, "Okay, Harry, let me help you. Let me help you figure out how you could do this central and art line." He sat with me. He helped me position my chair, and then I did one procedure with him. And after that, I did many after him. So it just takes one person to kind of believe in you that yes, you can do it, and you need some people like Dr. Patrick and Dr. Cook to support you in your journey. It does really help us. Thank you.
Thank you very much, Dr. Dhaliwal, for an absolutely fantastic and inspirational talk. A great examples of allyship from Dr. Lara Kirk and Dr. Andy Kirkpatrick, who we know very well. We do have some time for questions and answers before the break, and I invite everyone to put those into the Q&A forum, or if you're on the panel, I think you can even undo your microphone and ask them verbally. You know, following along the lines of Dr. Shukalik's presentation, maybe I can start by asking you what your advice would be to emergency staff when it comes to caring for patients with disability, and how can we be better allies?
Like, one thing is I've noticed that, I mean, I don't need sympathy. I need a lot of empathy. And if I'm having a problem, if I'm having an issue, I would like you to empathize and help me solve that problem. I've noticed that whenever I've been to the hospital, like in a wheelchair, and people have not known me that I was a physician, yes, their outlook towards me was very different, and at times biased also. But I mean, any amount of empathy you can show us, that would really help. I mean, for us, whenever I get sick, I'm looking for some ray of hope. And obviously, you're having disability, and so any amount of extra disability you get on top is exponential for us. Like, I had a recent stroke, and I was in the hospital for another 2 months, just 2 months ago. And so having that extra empathy, giving us some time to, not rushing things over, giving us some time to process the recent illnesses and to get over it would really help. So yeah, I've seen these people, doctors even trying to rush things over. Okay, we need more beds, we need to rotate the patients. So yes, that does. I know that we have issues with that too, but it will be helpful if you give patients more time to process their illnesses and to get over the disability.
Thank you, Dr. Dhaliwal. Katie Lynn has a question, and she's very thankful for you sharing your story and your inspirational resilience. She wants to know, though, from a patient perspective, are there particular community resources that you think would be very helpful, and that we may be wanting to connect our patients to in the emergency department that they may not already be aware of? Are you able to address that?
I'm not sure what, when I was there at Alberta Health Services, I was not sure what was available at that point of time at the EHS, but I'm not sure if there's anything new right now, but I'm not aware of any overt community resources available for me to refer the patients to. I do remember we did make up a disability committee in the hospital and the university for disabled students, but I'm not sure if it's still functioning or not. But that was a step in the right direction. But I think it was disbanded after a year and a half. But I would recommend if possible, that we should have a disability committee in the university, uh, especially for disabled students coming through our pathway into medicine.
Thank you. There's a comment from Dr. Colleen Carey, who I don't know if you can see it in the chat window. I don't know if you remember, but she was supervising you in the emergency department when you were an IMG just before you started your neurology residency. And she remembers a patient ally who had epistaxis, and you were taking care of the patient, and the patient was very accommodating and tried to bend over so that you could, I don't know if you were doing cautery or packing, but it was heartwarming, according to Colleen, it was heartwarming to see how much some individuals care and want to help individuals with limitations and special needs to succeed. So I don't know, do you have other thoughts on or examples of how patients can be allies for physicians?
No, I'm not sure how patients could be allies, patients with disabilities. I think it should be the other way around, where how doctors can be bigger allies to patients. I think it's more understanding with disability. When I was in medical school, I thought I knew what patients are going through. I really thought so before my accident. But when I had the accident, I got the wheelchair. Then I knew I had no idea what people were going through. Now I had a better understanding and I could empathize more. So I would recommend that if you want to really feel what it feels like, take a wheelchair for one part of your shift and work in a wheelchair, use the hospital in the wheelchair, go around in a wheelchair for one day or even half a day or even 2 hours, and that will give you some perspective of what patients are going through. Patients are what, so some kind of patients in wheelchairs are going through. I know Dr. Rigby is there too, probably like in the ER at Calgary. I remember I was there when he had this accident that time, and I was very taken aback by many of his ER colleagues and friends coming together to help him out. That's what I'm looking for. That people coming together, colleagues and friends and doctors, to help people out with disability, give them time to heal, give them time to figure out things so that they can move on and contribute in whatever way they can.
That's absolutely brilliant, Dr. Dhaliwal. And for those of you who are joining us from outside of Calgary, Dr. Rigby is one of our emergency physicians, shares a similar story, also extremely inspirational, and is really providing a great contribution to emergency care still here in Calgary. And there's really some good wishes coming through the chat window from Kelly Sherlock, who worked together with you in Dr. Dunn's lab here in Calgary, and she's wishing you all the best.
Thank you again.
Great. Well, we are coming up to the end of the hour. We have a break period that we will take until 5 minutes past 10 when we will reconvene for our next speakers. So on behalf of the entire department, the Hodsman Planning Committee, Dr. Dhaliwal, I wanted to thank you for joining us from Fraser and sharing your inspirational story and being part of our very special morning in the Hodsman Lecture.
Thank you for having me again. Thank you, everyone.
Take good care. We'll see you all at 5 past 10.
Thank you.
Mountain Time. The Hodsman Lecture Program. Just reflecting, it's very special day, the 1-year commemoration of the declaration of the pandemic, and reminds me that the last year's Hodsman Lecture was actually held on the cusp of the pandemic, a few days before emergency measures were declared. It was the first time that I had ever heard of the term physical distancing or social distancing. So clearly appreciate everybody's collaboration on a virtual event, and hopefully we'll be back face-to-face next year. But first, let me welcome our two next speakers. I'm very excited to have the opportunity to introduce Bonnie Healy and Patrick McLean, who represent a wonderful collaboration in research and First Nation leadership Again, I'm going to put details of their bios into the chat window for you to scan. But it's a real pleasure to introduce Bonnie Healy, who is a nurse and has an important leadership role in the Blackfoot Confederacy. She's the health director and involved in a significant amount of research activity that we're collaborating on. Dr. Patrick McLean, I know very well. He is the assistant scientific director with the Emergency Strategic Clinical Network, a PhD sociologist with an adjunct appointment in the Department of Emergency Medicine at the University of Alberta, and a prolific researcher and successful academic doing lots of work with emergency medicine, both in relation to First Nation experience in the emergency department, as well as broader topics, including violence in the workplace. So without further ado, I know they have a full presentation to tell us about their research. I will turn things over to them. Thank you for coming. Thank you for joining us.
Thanks so much, Eddie. We can have the next slide. So we will be talking about quality of emergency care of First Nation members in Alberta. It's just initial results of an ongoing 4-year research project. Next slide. So Bonnie, would you like to introduce yourself and talk about your disclosures?
Thank you, Patrick. Good morning, everybody. My name is Bonnie Healy. I'm a member of Kainai Nation, also known as the Blood Tribe in Southern Alberta, with a fairly large population of about 13,000 members and the largest land-based community, First Nations community in Canada. I'm happy to join you here today. I have a number of research grants that I'm partnered on. I'm partnered on a Public Health Agency of Canada grant with the First Nations Health and Social Secretariat Manitoba, looking at developing a Canada-wide opioid report, but and following what Alberta has done with the First Nations opioid report and recoding the data. And then I'm also partnered on the Canadian Institute of Health Research on iHealthy, so the Healthy Life Trajectories with Manitoba, and then I'm partnered on a number of CIHR grants within Alberta with Patrick McLean and the University of Calgary.
Yeah, and then I have grants from the Canadian Institutes for Health Research. And as Eddie mentioned, I am employed with Alberta Health Services in the Emergency Strategic Clinical Network. Next slide. So we have 2 learning objectives: to understand why emergency care is a unique context for anti-racist work, and specifically we'll talk about anti-Indigenous racism. And then we'll reflect on practice and systemic changes that would allow the healthcare system to better serve First Nations. Next slide. So we have 2 studies we'll talk about. This one is published, was a qualitative study. In 2018, we brought together people from nations around Alberta with health systems leaders and providers to talk about First Nations emergency experiences. Next slide. And the current study, funded by the Canadian Institutes for Health Research, is mixed methods, so we'll have some quantitative results. Next slide. We have a number of partners, and we're very pleased to have representation from all treaty areas in the province. So Musqueam's Health Services, Yellowhead Tribal Council, Treaty 8 Organization of First Nations, Blackfoot Confederacy, and the SNTTC. The main partner for the research is the Alberta First Nations Information Governance Center, where Leah Bill is the executive director and works with us. Next slide. A large team. Importantly for this project, we have an elder advisory with elders appointed from each of the participating organizations. Next slide. And Bonnie, could you speak to this slide?
Thank you, Patrick. So with my work with the National Center, the First Nations Information Governance Center, the ownership, control, access, and possession of First Nations information came into be when we started the Regional Health Survey. And so what it does is it just asserts governance over First Nations information. So follows the lines of making sure that mitigate harm that would come to any First Nations, and ensuring that most research is Indigenous led and respected governance systems that are within nations are in place. And most of this takes place with data sharing agreements, MOUs, and it's also mentioned in Tri-Council Policy Chapter 9, working with Indigenous research with Indigenous populations in Canada.
Yeah, and we're reflecting those principles in that all of the research data is, the qualitative data is held by the AFNIGC, and the communities own that qualitative data, and then we're co-producing the results. Next slide. And so we have adopted a definition of racism for our project, and since the beginning we've had a focus on racism. So we say racism is a system, its structures, policies, practices, and norms resulting in differential access to goods, services, and opportunities of society by race, in quotation marks, knowing that race is a social construct. And we've also approached the idea of racism, and this Bonnie will speak to, from Indigenous perspectives.
We found it important to really speak to the experiences that Indigenous people are experiencing in the ED departments in their own Indigenous language. Indigenous language is very descriptive in nature. It has accountability built into it. So it wasn't just simply looking to see if racism existed in these systems. It was more about understanding how the person describes their experience in their Indigenous language, and then really trying to find some solutions to ensure that what people go into the system for is to get put on either a healthy path or to get the healthcare needs that they are seeking, and ensure that how they're treated in these systems is ideal, and no harm comes to them while they're in these systems. Okay, Patrick.
Thanks, Bonnie. So yeah, starting from the perspective that racism is operating in emergency departments, not whether there is racism. Next slide. So part of the genesis of the project is we know that there are worse health outcomes consistently reported for First Nations people in Canada and in Alberta. That stems from social, political, and economic inequities, but there are also inequities in health care. Next slide.
Sorry, Patrick, if I could just maybe mention a little bit about that slide.
Yes,
what a lot of service providers don't know that are provincially based is First Nations health systems don't have federally funded primary care networks within their health system. And First Nations people are not included in the Canada Health Act, the Alberta Health Act, recognizing their distinction and their treaty right to health. And this is causing some concerns because we're seeing in the data how utilization of ED departments is reflective in the data.
Absolutely. Next slide. And so just exactly what Bonnie was saying, that there is limited access to primary care. That's been reported widely in the literature and linked in some studies to greater use of emergency departments. National data from the First Nations Information Governance Center 22.6% of First Nation adults reported that a physician or nurse was not available in their area, 2015, 2016. Next slide. And we have also seen reports of differential outcomes by race and ethnicity in emergency departments. That's been found for triage, wait times, diagnosis, analgesia, leaving without being seen, and against medical advice. We've also seen reported in the literature that if we're addressing Indigenous health, that should be tailored to the emergency care setting, not a one-size health system approach. Next slide. So some of our quantitative results, we've got 2012 to 2017 data, 111 facilities. So it's about 11 million emergency visits in our data set by 3 million unique people. First Nations people, according to the Alberta health data that we rely on, make up 4% of the provincial population, but 4.8% of unique emergency patients and almost 10% of all emergency visits in the province. And that's not evenly distributed. Many hospitals have much more, and there are a few hospitals in the province where the majority of patient visits are by First Nations people. Next slide. Our colors have changed a bit from what we had, I guess, when it got translated into the deck. But here we have First Nations in red, and non-First Nations is the orange here. So this is showing the age and sex standardized emergency visit rate per person for 2016, 2017. And we see provincially, non-First Nations people use the ED about once every 2 years or half a time a year, whereas it's more 1.5 times a year for First Nations people. And it's similar in every part of the province, including Edmonton and Calgary. Next slide. When we look at transportation, we see that First Nations persons live further from emergency facilities. So 25% of First Nations emergency visits are by patients who have to travel more than 24 kilometers to reach the nearest emergency facility. And for non-First Nations people, the same statistic is 8 kilometers. That's not by accident. There have been decisions about where hospitals have been built historically. Next slide. In terms of dispositions, we see much higher rates of leaving without being seen or against medical advice among First Nations people, slightly less admissions, and transfers about the same. Most other patients are discharged. Next slide. So we've met with elders to co-interpret the quantitative data, most recently in February of 2021, virtually because of the pandemic. And elders have explained leaving without completing treatment in terms of issues accessing transport to and from emergency departments, discrimination in the system or racism, and leaving care to fulfill family responsibilities. Next slide. So this is an example of racism and leaving without being seen. The physician, we've interviewed 16 physicians and nurses for the project. And this physician told a story from when they were a resident, and they say that they saw a girl who was First Nations who they were sure had appendicitis, but that the physician who was actually training them was, and the quote is, running her mouth about Indians, like going on a big racist rant just at the nurse's station, kitty corner to where the patient was. And then the patient hears this, gets up, is taking the IV out and bleeding on the floor. And the physician telling the story said that they begged the patient to seek care elsewhere, but didn't know if that had happened. So we'll have the next slide. In terms of the experiences we've heard about, when we engaged patients in the provincial meeting in 2018, we heard about a lack of access to services, concerns about stereotyping, particularly around drugs and alcohol use, fear of child services being called, which was not on my radar when we started the research, certainly. But with 70% of youth in provincial custody in Alberta being Indigenous, that concern makes sense. And providers can lack understanding of First Nations, not knowing history of residential school, for example. And then we also heard that unless there's an explicit racial slur, it can be hard to tell if poor treatment is derived from racism. So I, as a white person, I might think someone is having a bad day or the department is very busy, but I don't have an added anxiety in emergency as a rule that anyone is being racist towards me, while First Nations people do have that experience. Next slide. Then there were discussions of expectations of different treatments. So that there would be profiling, that there would be questions about drugs and alcohol, no matter what someone was presenting for. We heard that this leads to hospital avoidance. One patient told a story about a brother who passed away without going to hospital because he'd said he didn't like the questions that were asked there. And we heard about concerns about specific hospitals. So people from all around the province had a sense that there were some hospitals where they wouldn't have good care, and people talked about undertaking long drives to avoid some hospitals and go to others. Bonnie, would you like to add anything here?
Sure. I think the First Nations expectations when they come into a treatment center is to, I guess maybe get the treatment that they're expecting to go to. Oftentimes too, I think what Patrick was explaining is if they come in by ambulance, there generally is no ride for them to go home, and their services, health services, are only open Monday to Friday, 9 to 5, and really there's no way of contacting anybody if it's after hours or on weekends. So that leaves them in, I guess, a bit of a limbo or crisis if getting transportation home is not falling within those business hours. And so oftentimes choices will be made by individuals to not go to hospital because they know that there's a possibility that they could get stuck in a city center without transportation home, or if they've had a negative experience in the past or witnessed family members with a negative experience. Okay.
Thank you. Yeah, and important that can tie into the leaving without being seen statistics. If there isn't transport and someone's chance to get home is only when a ride happens to be available. Next slide. So we heard about changing the experience. So a desire for providers to know colonial history and determinants of health, but also equity approaches. So recognizing that not everyone is starting from the same place in their healthcare past experiences. So it may be that if someone's experienced trauma or an assault, there needs to be different approaches to asking permission for a physical exam, or when taking history around drugs and alcohol, there may be a need for an explanation for why those questions are being asked, that they're medically relevant and not motivated by stereotype. We heard about creation of ethical spaces, so coming together, recognizing that non-Indigenous and Indigenous peoples in Alberta have shared but separate histories, and so coming together and working together to address the common issue of racism. And systemic approaches, so that it doesn't fall all on individual providers to try and figure out how to do this, which is a recipe for burnout for the providers who are going to be trying, because they're making up everything for themselves, and isn't going to be a broad-based solution. Bonnie?
Sorry. Yeah, I think that where we've seen some success with other Indigenous population groups to really address health equity approaches is with the Maori and in work developing their health equity framework. I've been in some discussions with Alberta Health Services and the Indigenous department there to also look at a health equity approach. And really what we want to support providers is to really understand the colonial history that have led us to the social determinants of health and what we're actually seeing within the data, and A lot of it stems from policy and legislation of the Indian Act, the Residential School Syndrome or Residential School Initiative, and the First Nations Health Policy, which all have an impact on the health status of First Nations today. And then the work that we've done with when I was with AF&IGC, so I'm the former executive director of the center, is worked extensively with with Willie Ermine in the creation of ethical space, and Dr. Reg Crowshoe. We've worked with the University of Calgary and the province of Alberta and federal government to really establish these relationships. And the ministry had worked with us for a couple of years, and we utilized some Alberta Innovates funding to train over 1,000 individuals in OCAP certification. And most individuals were not all just First Nations. There were academics from all the universities and individuals from both provincial and federal governments. And so how we're approaching racism is not just, you know, case by case, but really addressing it from all levels, from legislation, from policy, from the relationships that exist, from the data that is being housed, how it's being spoken about, and to really get to a desired relationship that ensures fair and equitable treatment of Indigenous populations, where there's a deeper understanding of the distinction of each First Nations individual.
Next slide. Thank you, Bonnie. So this is the Maori framework Bonnie had mentioned. Next slide. And so our recommendations or practical steps providers could take is treating each patient as a unique individual, complete investigations at each ED visit, learning and reflecting on stereotypes and biases to self-correct during encounters, learning about the history of First Nations, including locally. Next slide. Asking providers to recognize that resources outside the ED are not the same for First Nations and non-First Nations patients, that First Nations patients may have past negative experiences with healthcare, and that stereotypes can be activated by your words or actions regardless of intent, and so being conscious of that. Next slide. So one provider we interviewed talked about trying to mitigate the stereotypes around substance use, and says that he might ask permission to ask about smoking and drinking, or to couch and preface those questions with an explanation of why it's medically relevant. Next slide. Practical steps for departments, because again, we think this is an organizational or systems level need. Take for granted that racism impacts health and healthcare, so each ED doesn't do a new project to determine if there's racism in their site. Implement policies and practices that support equitable care, create safe and well-moderated learning opportunities that would involve First Nations professionals and educators. Next slide. Build formal relationships with First Nations to familiarize providers with the realities that First Nations face and resources that are available locally, and enable the ED to understand and work to address the expectations of the community or community health services for the emergency care system. Next slide. And then standardizing triage, care, and discharge pathways. Some evidence suggests that when care is very standardized, as in stroke care, for example, there are less disparities between racial groups. To develop processes for reporting discriminatory behavior and for a restorative follow-up. And then because physicians see in the emergency department the outcomes of social determinants of health, EDs and emergency physicians are really well placed to be advocates for resource allocation and quality improvement inside and outside the ED. And next slide. So that's it for me. Bonnie, do you have closing comments?
I just want to thank the organizers for the invite and the opportunity. I think it's important, and I didn't include this in my introduction, I am a trained, trauma-trained ER nurse. I worked in the University of New Mexico Level 1 Trauma Center. Also worked on the downtown east side as a frontline first responder in Vancouver for about a decade. And so my 31 years of nursing do have some ED experience and completely understand and have, I guess, maybe some good understanding of what happens within these systems. I experienced my first case of burnout in nursing from this system, and some of the things that individuals have to do to survive them and to ensure that you're continuing to be a good health provider, and that you can care for others without causing harm in your practice.
A huge thank you from the planning committee and our department to both of you for joining us and sharing this incredibly important work, incredibly practical as well, with some really key messages. So we have a couple of questions in the chat window and the Q&A forum. One of them is, well, two of them are actually directed to the Indigenous liaison role that exists in a number of the larger emergency departments. And the question, I guess, is whether, so Haley Cochran wants to know if maybe this is a role that needs more presence in the emergency department, if I understand correctly. And I believe Stephanie Vandenberg wanted to know if your study uncovered any feedback or thoughts on the role itself and how it might help improve the First Nation experience in emergency departments.
Patrick, I can maybe speak to a little bit. I'm very familiar with the liaison roles that have been established since the 90s, I think, within the health system of Alberta. And what we're finding is, or at least on the Indigenous side, and I think more extensive research needs to go into and evaluating these roles and the effectiveness and the impact. But if they're not a health professional of equal footing, a nurse or a physician, how they liaise is a cause for concern, because the effectiveness and the impact on their voice is not being heard.
Yeah, we did have some feedback. We'd heard some positive things about the roles. I mean, I think that the people who have those roles do amazing work in challenging conditions. We also heard that it can be a burnout role. There's one of the questions mentioned a very high workload, which I think is true. So I think one of our recommendations is that it isn't for one or two people in a department to address these issues. It's a whole department approach.
Thank you. Ian Wishart has a question which addresses maybe something that you just touched on with the liaison role and how it's often not a healthcare professional on the same footing. What efforts are underway to improve or increase the number of healthcare providers that identify as First Nations? It seems that would be a critical step forward. I don't know if Bonnie, you wanted to start with that?
Sure, I can speak to it. Health Canada and FNIB, First Nations Inuit Health Branch, had an initiative called the Aboriginal Health Human Resource Initiative. And so there's been efforts for over 30 years to recruit and retain Indigenous nurses and doctors in Canada. A number of universities have done some excellent work in establishing Indigenous seats within the medical faculty. Both University of Alberta and University of Calgary have done this for many years. My cousin, Dr. Darcy Tailfeathers, was the first Indigenous student enrolled at the University of Alberta in '88, I believe. Unfortunately, he was killed in his 3rd year of school. And his sister is now one of our Blackfoot physicians, Dr. Esther Tailfeathers. And we're really fortunate in the Blackfoot Confederacy. We have a large number of Blackfoot trained physicians, nurses, and doctors. Last I took count with Blackfoot nurses, there's well over 75. There's about a dozen Indigenous Blackfoot doctors. And so we still strongly support and do whatever we can to mentor Indigenous physicians and nurses. And I'm partnered on a NEAR grant with CIHR and Dr. Janet Smiley nationally to train 100 epidemiologists, Indigenous epidemiologists in Canada. Currently, right now, we have less than 10.
Thank you so much. We're going to slip in a kind of a research question. It comes from Kelsey, and it's related to how First Nation specific data is collected or acquired. And if I can, how did you get, how's this data available? Yes, sorry.
I tried to answer it in the Q&A box, but maybe I can elaborate a little bit more on it. So from the years we were paying into health premiums from 2000 to 2009, the province needed to understand who qualified to have their health premiums paid for by the federal government. So a identifiable list, the Indian Registry, was transferred to the Ministry of Alberta Health Surveillance, and a unique life indicator was developed for each individual that qualified to have their health premiums covered by the federal government if they were First Nation status Indians. And so that happened from about 2000 to 2009 without any relationship to First Nations. And then when the province were requesting the Indian Registry for a second time in 2013, it was brought to the Chiefs of Alberta, so the Assembly of Treaty Chiefs of Alberta, and there a resolution was passed, and the Alberta First Nations Information Governance Center was mandated to work with the Ministry of Alberta to develop a First Nations health surveillance system. And in 2013, we, the First Nations, AFNAGC, and the ministry all applied jointly for access to the Indian Registry, and we were accessing the registry for all of Canada, just because we have a large population group of First Nations that live in Alberta but are not from or not registered to an Alberta First Nations community. So this is how we could get to the core of the information. That application, for whatever reason, took some time to get transferred, the Indian Registry to get transferred to the ministry. But this past year, during COVID, I worked extensively with Minister Miller in Indigenous Services Canada and the province to get this transferred to the ministry. So data cleaning and data linkage is occurring now, and a joint First Nations Health Information Governance Agreement is developed, and it needs to be signed. So we are working extensively with the province to and AFNAGC to report on the health status of First Nations. And so this is where you see this identifiable data. And individual communities are also working with the ministry to share their membership list or their residency list and to do data linkages so that they can get health status information back on their communities.
Thank you for such a thorough response. We are so incredibly fortunate to have both of you speak to us today on such an important topic. You know, hopefully it's a kind of a tipping point, because it's rare to have a First Nation speaker and have such insight on from the work that you've done. I'm going to draw this session to a close. Lots of questions in the chat window. Maybe we can think of a way to get those to you and share the responses. But I'm going to enter us into another short break and make sure that invite everybody back at 10:45 Mountain for Dr. Esther Chu's presentation. Thanks again for joining us.
Thank you.
Thank you very much.
Make sure that we give our next speaker the time that we want her to have. Though she truly needs almost no introduction, I can't actually tell you how thrilled we are that we were able to get her as a keynote speaker. Dr. Esther Chu is an emergency physician and a professor at OHSU in Portland, Oregon. She's done an incredible amount of research and work on substance use disorders, violence, women's health disparities, and gender medicine, to say the least. She co-founded the Equity Quotient, which is a company that conducts assessments of healthcare company culture, and is a founding member of Time's Up Healthcare, which advocates for workplace safety and dignity for women. She was a past president of the Academy of Women in Academic Emergency Medicine and is a very popular health journalist who writes for NBC and Self Magazine, has a regular column for The Lancet, focused on health disparities, and also appears as a medical expert on CNN and MSNBC. I could honestly go on and on about how incredible she is and the amazing work she has done in her social justice activism and her advocacy work. But I will let her talk and her work speak for herself. So without further ado, Dr. Esther Chu.
Thank you. I appreciate that introduction. And I just want to take a moment to really acknowledge the talks that went before. I felt so honored to be in the room listening to them. I had moments where I was in tears back here, and I also took lots of notes because I thought there was lots of learning there. And I just thought the transparency and the vulnerability shown by all the speakers, as well as just like the learning and the practical application. I made a note to myself, for example, to actually try to be that person that Dr. Dhaliwal mentioned, that advocate that you can count on. It's not a role I've thought of before, and I really feel like there were transformative moments. So I feel like I am coming on the heels of really some of the most moving and incredible talks I've heard of late, and it makes me feel like a little bit of an imposter syndrome here. I'm just wondering what I can add, but hopefully some of this will be an echo of the kind of important themes that they mention, and I hope also it will stimulate simply more discussion from all of you about what you will take back to your practices from the entirety of today's event. As mentioned, I am co-founder of Equity Quotient, and I will not mention it further in this talk. So my general objectives today were to discuss a framework for conceptualizing health inequities. And I hope you're not too tired about COVID, but COVID to me was such a good example. And it honestly was one of the first times that I really tried to stop and think comprehensively of all the factors that lead to disparate health outcomes for vulnerable populations. I then wanted to walk through some examples of inequities and how they play out over the course of a patient's emergency care experience, and then discuss how we might take some steps towards building equitable environments that are also equitable in a sustained way. And this is where I really have a lot of humility and hope that that the discussion will reveal further things that you all feel are actionable immediately in our practices, as well as over the longer term. So just to start with definitions, and I know you've heard some definitions earlier today, I try to think of equity as what is it that we want to accomplish in practice? Functionally, what is it that we mean when we say we want to be more equitable? And there's a lot of formal definitions out there, and this is what I kind of keep in my head as I'm going through my day. I think equity would be the circumstance in which every patient walks in the door in our healthcare facilities and feels that they were respected and cared for to the best of our ability. They have no reason to doubt that, and they have utter confidence in that fact. And then I think another part of equity is when we measure, we find that this is statistically true. We're able to confirm that with important patient-centered outcomes in terms of their health. And unfortunately, what we see in the data suggests that the experience is also not there. And I'm going to start with COVID now and I'll be talking about COVID for a little stretch, and then I promise I'll bring it back to our emergency care practice in general. So just some data from Ontario. This may be familiar to you. This is just looking at test characteristics and positivity among immigrants, refugees, and other newcomers in Ontario. This is a little bit, I can't believe we're more than a year into the pandemic, but a little bit dated, but I think as more data has emerged, we've only found these factors to be more true. So some key findings. So although immigrants, refugees, and other newcomers make up just over 25% of the Ontario population, they accounted for this disproportionate percentage, 44% of all COVID-19 cases to that point. They found that rates of testing were lower for immigrants and refugees compared with Canadian-born and long-term residents. And they found that refugees had the highest percent positivity among those tested. And you can see the differences there. The highest rates of positivity were in immigrants and refugees, where a majority were racialized in Canada. So from Central, Western, and East Africa, South America, the Caribbean, Southeast Asia, and South Asia, and also who were more likely to live in low-income neighborhoods. We know this, that being a healthcare worker accounted for a very high percentage of positive cases, particularly in women from specific countries. So 53% of those from the Philippines, 64% from Jamaica, and 76% among those from Nigeria. We saw very similar patterns on all these things in the United States. So both in terms of where resources went and also ultimately, in addition to testing and case positivity, rates of disease and death. And so just to add a little bit to the data I gave you, we saw very early on stark differences in not only how often you got tested, but where you got tested. So here, if you were African-American or Black, you were about half as likely as Asians to get tested in the ambulatory care center. I think generally stating that you're not likely to get tested early. You need to get sick to have to go to the hospital, to even get hospitalized before you were likely to get tested for COVID. This translated into treatments too. This was a study of cancer patients who were diagnosed with COVID-19 and then received or didn't receive treatment. And we found that in this study of over 2,000 US adults, Black patients were approximately half as likely to receive remdesivir as white patients, which actually very interesting aligns with the lower likelihood of receiving early COVID testing, and likely is associated since some of these treatments need to be started early and with confirmed disease. And so like all together with all these differences in resources, in testing and, in treatments, basically we saw very, very different death rates in the United States. I think we pretty early on started tracking data disaggregated to some extent by racial groups. And what we found was that adjusting for age, Pacific Islanders, Latinos, Blacks, and Indigenous groups were much more likely to die from COVID. And this played out very starkly in the experience of entire communities. I mean, just think of the difference. If you're in a community where 1 in about 600 people has died, versus if you go all the way to the bottom, 1 in 16 or 1700 has died, that makes a tremendous difference in how many people who have directly touched your lives, who you are close to, or or the people you love have died, makes a huge difference in your experience in this pandemic. And that's what we've really talked about, is how people were able to be in the same country devastated by COVID, and yet have feel very different impacts in their personal life, in their emotional experience this year. And I think it probably explains a lot of the differences in how people felt about things like restrictions and getting vaccine. Speaking of vaccine, just one small point about the science, because this is the the initial phase 1 report study for the Moderna vaccine. And I'm just going to show you the enrollment table, and I want you to look at the race and ethnicity groups. And I will say, without going line by line, it is uncomfortable to look at an enrollment table by race and ethnicity that has that many zeros. And I think even in a small study in for a medication to prevent a disease that has disproportionately affected racial and ethnic minorities, to see that many zeros lined up is an incredibly sad thing. Of course, Moderna got a lot of feedback about this, and I thought it was a good real-time example about how public outcry can actually put scientific pressure, so that by phase 3, Moderna was later to release their data because they were not going to do it unless they had adequate enrollment across subgroups. And all this to say that, as we walk through all these differences and people are like, why are there such disparate outcomes? It made me think, what are all the things that contribute to these disparate outcomes that lead to such differences in death rates? And I think the more I thought about it, the more I was like, it really is so many factors all coming together. And so you think we started this pandemic with a ton of baseline differences in social advantage based on not just race and ethnicity, which I'm focusing on in this talk, of course, but the innumerable factors, including sex and gender identity, sexual orientation, disability, religion, language, age, country of origin. You can go on and on. We have a society where every policy feeds into baseline differences in social advantage. And then we entered the pandemic, and there were differences in exposure to disease, in susceptibility to contracting disease, and your likelihood of progressing to severe disease. And then once you hit the healthcare system, so many disparities in the care that you receive, from diagnosis to the decision to admit you to the hospital to give treatments. And then finally, disparities in evidence base, which may not affect you in the moment, but in aggregate over time affects what we know about our entire population and how confident we feel moving forward with recommendations that are relevant to a very diverse group of people. And so, I have examples kind of in these boxes, but I think you can walk through and think about it, not only for COVID, but really think about when we are grappling with an inequity of any kind in any disease process and any of the care that we give, we really have to think about it as a broad problem that is likely multifactorial, that has impacts from the environment even before a patient hits our door, and then often gets compounded by these layered factors that all lead to disparities. And I think when you just get stacked up all these different disparities in the way that you are exposed to disease, are at risk for disease, and then fail to receive the kind of timely diagnosis and care, those things all come together and lead to unequal rates of illness and death. And I think we see this all the time under our very noses in our clinical environment, but I think we saw it in such real time across huge populations during this pandemic. It was truly, really just the most striking, like I can see it from space kind of manifestation of what it looks like to have fundamental inequities that literally make the difference between life and death. So, of course, we're going to focus from here on on this part, but I guess all of that to say that when we think about a patient and their interaction with the piece that we really feel like we have so much ownership of, which is, the four walls of our ER, of our hospital, or of our clinics, we just have to keep in mind that there is a whole universe in which the patient lives, and they have already experienced so many compounded factors by the time they get to us, that really it becomes an issue of recognizing that and making sure that we don't contribute further. And then hopefully at some point, thinking about the ways in which we might actually balance out those inequities. But from the perspective, excuse me, from the perspective of our practice in the emergency department, I mean, some of the things we can really think through are, not quite at our walls, but even before our walls, who is it that has access to our care? And what factors into their arrival? And can we influence that at all? Can we make even just access to us so that we can provide the care that we want to provide more equitable? And then from the moment people actually get to us and onwards, how is every moment from triage and then through their care, their disposition, their final hospital course, or their final course with the illness that brought them to the emergency department. How are those things different based on patient characteristics or identity? And then what happens when people leave the ER? I won't spend a ton of time on that, but there's a trajectory of a patient's course through their illness, and how much can we influence even the time before and the time after, because care really is not limited to our walls anymore. There's a whole continuum that we are really responsible for increasingly. So to just go through a few examples, and this is the kind of talk where we could spend all day thinking of examples, but I'll try to just walk through, what are the barriers before people get to us and then thereon. But this is a small study I did a few years ago where a colleague wanted to do a study examining experiences of our transgender and gender non-conforming patients. And we actually thought of this as an ED-based study until we realized that it was tremendously hard to identify and recruit our patient cohort because we don't collect data on patients by gender except a binary defined gender. And so it was this huge methodologic barrier. And then we realized, as we did more reading, that we were unlikely to be successful recruiting because this is a population that for very good reason tends to avoid us. And so we ended up doing community-based recruitment and doing a series of focus groups out in the community. And we were able to recruit 32 focus group participants over 3 focus groups. And we found that 44%, almost half, reported they would avoid the ED altogether when they clearly needed acute care. And there were many, many factors that influenced this ED avoidance, but many of them were fear of discrimination, having had long waits, and really profoundly negative, traumatizing previous experiences. This keeps our patients from us. And if you can just imagine any patient saying, I was so traumatized by a visit that I, in which I expected to come and receive care for an emergent problem, is just, that is part of our own creation of a barrier to coming back to us. So it falls within our purview. The other thing is just to think of all the things that are barriers to patients who seek our care and cannot get it. I mean, there's ones I will not mention, like just even distance and access to a hospital for care at all. But even these subtle differences, even when we think that patients are accessing us freely. And so this is a study looking at ambulance transports from a huge Medicare data set representing over
I think we might have just lost Dr. Chu. We're just going to give her a moment to pop back in. Sorry, guys. Maybe while we have Dr. Putty and Dr. McLeod up and as panelists, we'll move on to them and then jump back to Dr. Chu when she's able to return. I'll give them a sec to just pop their videos on, since obviously I gave them almost no heads up. But I just wanted to introduce the two of them. They are incredible Emerge docs in our department, who most of you know, and they're also the leads of our working group on our equity, diversity, and inclusion group in our emergency department. So we were saving them for sort of the end because we obviously wanted to get a lot of inspiration from Dr. Chu's talk to sort of build towards our equity and diversity within our department. But we'll maybe have them kind of go first, talk a little bit about what their next steps are, and then we'll bring Dr. Chu back in to sort of continue with her presentation.
I'm back and I'm happy to wait or go. I'm so sorry.
Why don't you keep going? Is that okay? Let's do that. We'll come in.
At least I got through the intro of you guys, so.
Oh my gosh, I'm so sorry. I'm so sorry I got booted out, and hopefully that won't happen again. I had to switch networks. I don't know how long I kept talking after I was off. Were we done with ER transport?
No, we missed that.
Okay. This is a study of Medicare enrollees from more than 4,000 zip codes. And I think the bottom line is that even within the same zip code, we find that Black and Hispanic patients are systematically transported to a different body of EDs, to safety net EDs, compared to where their white counterparts in the same zip code are transported. So I just want to capture the picture that there's so many different factors related to ED access that that sometimes there are kind of structural or individual biases that collide to provide people with very different access, even when transparently they should have the same, for example, distance access to our emergency department. And then, of course, all the things that are different once patients get here. And so a study looking at different metrics of emergency department care outcomes among adults in the United States over this 11-year time period. And what they found in this study that was that adjusting for other demographics and visit and clinical characteristics, including the ESI score and symptom category, they found that Black patients were 16% less likely to receive any imaging and 4% less likely to have a blood test. Black and Hispanic patients were 10% likely than white patients to be admitted to the hospital. Black patients were 1.26 times more likely to die in the ED or hospital, and Hispanic patients 1.12 times more likely. And I'll say the other thing is, although these factors were adjusted by ESI score, they also found that despite initial clinical characteristics they could capture from this data set, they found that Black patients were systematically assigned a lower ESI score at similar clinical characteristics. There's also a wealth of literature in outcomes related to all kinds of cardiovascular care, including heart attacks, just the treatment and workup of chest pain and stroke. This is one relatively recent study looking at racial and ethnic disparities in utilization of thrombectomy for acute stroke. Looking at over 200,000 admissions to 173 endovascular centers, they found that mechanical thrombectomy and IV TPA was lower among Black and Hispanic patients compared to white patients. And they extrapolated to what this would look like if this were in the context of a clinical trial, and they created a number needed to harm or treat of 43, meaning that every 43 patients treated with mechanical thrombectomy, there would be one untreated minority patient. What I really liked about this study actually is that the discussion was very good, I thought. They considered a broad range of system and practice-based factors that that might contribute to this discrepancy, including what were the resources at hospitals that saw a mostly minority population? Were there different procedures around ambulance triage to stroke centers? Was there a different time to evaluation or time of presentation? What was the decision-making like at the bedside? And I think often when you read these clinical papers about differences in disease outcomes, the focus is often on biologic differences, like why is this population maybe not as responsive to treatment. But I think this study solidly accepted that there may be both system-based and individual-based biases that led to these kinds of differences, which I think is where the answers lie. You probably have heard a lot about how differently we treat patients with pain in the emergency department. And this study always stuck with me because I was like, even in children, where we tend to have lower tolerance, I think, for pain. I certainly have a very low tolerance for seeing a child in pain. But this was a study, a national study using this large population-based study, NAMSIS, between 2003 to 2010, almost 1 million pediatric visits for acute appendicitis over this time. And they found that Black patients with moderate pain were less likely to receive any analgesia at all compared to white patients. Those with severe pain were less likely to receive opioid pain medications. Overall, Black patients received opioid analgesia significantly less frequently than white patients. And just kind of bouncing from that, I mean, we could go on and on with the examples in which we see that treatment, selection of treatment, decision-making around doing labs, imaging, assigning disposition to patients, follow-up plans, how carefully we go over follow-up plans and ensure follow-up for patients. All those things are, you can account so many differences among patients based on a number of characteristics, race, ethnicity, gender, and so on. I think that the thing we want to move to is like, why are those things? Why are those things true? And I think the kind of concerning thing is that we have some fundamental differences, fundamental beliefs about the differences in people based on things like skin color or race. So this is a study from the Proceedings of the National Academy of Sciences, looking at enduring false beliefs about biological differences between Black and white people, even among medical trainees. And so they had 2 studies. The first column you can see is a general study population recruited from Amazon's MTurk. But the study number 2 took medical students in their first, second, and third years, and then residents as the second study group. And what they found was that these kind of beliefs were surprisingly prevalent. Even things like this, Blacks' nerve endings are less sensitive than whites, is something that a number of medical students and residents agreed with. And those kind of beliefs, while they're not universal, are consistent enough that you wonder if some of these ideas are kicking around when we make decisions about allocation of pain medication for people in even moderate to severe pain. And some of these things are just, are actually highly prevalent in the beliefs of at least our students and trainees. And I think we don't systematically teach the unlearning of these beliefs. I think we rarely address them head on. So they're sitting there silently. And I think we can, there's enough data like this. And if you look at these 2 tables, by the way, everything that I showed here, there was like, kind of consistent beliefs across both study 1 and study 2. Some of these I had never heard before, like white people have a better sense of hearing compared with Black people. And so you're kind of like, well, I don't know how that might manifest in my practice. But I think some of these things, beliefs in sort of skin thickness, nerve endings, muscle mass, those things actually feed into clinical practices that we do. And I think when we see a discrepancy in a policy, in a practice, I think we need to stop and have a lot of curiosity about the underpinnings of those consistent behaviors across our populations of patients. The other thing I want to say is that, particular to our practice, I would say increasingly over time, at least over the 16 years of my practice, these things have not gotten better. They have all gotten worse. So patient volumes keep on going up. I feel like we see higher acuity and complexity of patients. We have tremendous time constraints. ED crowding seems not to be going anywhere despite our huge science on it. We increasingly, and particularly in this pandemic, have been working under limited resources. And there have been, trends towards ED closures, either temporary or permanent, and those tend to disproportionately affect our patient population's access to ED, but also make the EDs that remain open more crowded, and make our work much harder over time. And so, when we work in these settings, all the things I've talked about that disproportionately affect our patient populations, they tend to be worse because there's so much pressure to be efficient, to be quick. And the truth is, when we have patients with social vulnerabilities, because of our systems and our structures and our own internalized biases, they need more time. They actually need us to do sometimes timely mental resets, or just time to figure out how we write our, the inequities built into our system or into ourselves. And so I think simply the environment in which we practice tends to compound social vulnerability. And it sometimes can be as simple as we don't have time to call in a medical interpreter, so we'll use somebody by the bedside, who maybe isn't prepared to do that kind of translation, or there's a patient with some kind of disability, or they're older and they're hard of hearing, and we just don't take the time to get a careful history because we feel the downward pressure of all these forces that affect us in the emergency department. So I do think that we are in a very particular environment where we ourselves are at high risk for perpetuating more inequity. It is hard to ask people working in these circumstances to do more and to do better all the time. And that is why it's, I think the fixes that rely on individual people to make choices are not sustainable, not in the current practice environment that we have. I also want to emphasize how much is built into our system that really works against our individual potential inclinations to act more inequitably. I hope you all saw this research letter that was published in the New England Journal of Medicine. It's not completely unique, but it definitely stimulated a lot of conversation, particularly with its relevance to COVID care of patients. So this was looking at more than 10,000 patients who had paired pulse oximetry measurement along with blood arterial measurements of partial pressure of oxygen. And there have been a number of studies like this. This is just the most recent. This was out of the University of Michigan. And what they found was that in aggregate, Black patients, so basically, I think this is much more about literal skin tone than a racial identity, but Black patients had more occult hypoxemia, so more oxygen saturation reads that were above this threshold of 88% arterial oxygen saturation by pulse oximetry. But then when you measured the arterial oxygen, it was a couple of points lower. And it was overall in this study, it was almost consistently about 2% lower in the arterial oxygen saturation. And I will say past studies were not binary. They weren't like white and black. There have been studies that show that across a spectrum of skin tones, the darker you get, the less the more likely you are to have occult hypoxemia. This is, of course, always concerning, but particularly in this era, if you like us, have had lots of patients who you triaged for home or for hospital based on a couple points difference in a pulse oximetry. This has the potential to have a profound impact on the differential outcomes that we saw in patients with moderate to severe COVID illness, and possibly could delay care and treatment decisions. So just to say that sometimes our very walls and structures and equipment are creating this path towards inequitable care. So again, it's not all up to us as individuals with good intentions to be able to fix the kind of really inequitable structures that we work in. We have to change the structures. And there's so many examples like that. Of course, spirometers have a race correction. We're in the middle of a big conversation about the race correction to estimated GFR. The American Academy of Pediatrics has come under fire for its race-corrected urinary tract infection guidelines in working up infants and young children with fever. That really tends to favor a workup, kind of triggers a workup with fewer symptoms if you are white compared to if you are Black or Hispanic. And so I think once again, we really have to turn a lens on all the things in our system, our very policies, practices, the physical surroundings we're in, and recognize how much of our inequitable care is reinforced simply in our practice environment and the cultures we have created. So I hope you're ready to talk about some solutions. I am not bold enough to say that I know what the solutions to these complex problems are, but I thought we could have a few touch points. And I'll start with implicit bias training and awareness, because I think this has really been pushed so hard at the institutional level across the last more than a decade. I would say since I was a resident, this was really a conversation about how what every hospital needed was for every worker to be aware of their implicit biases that they brought to the table, that made them treat different patients differently. And if we were just aware of it, we could fix it in the moment. And I think there's been such a big literature about this. And I think we are aware that implicit bias training can be helpful, but your motives have to be aligned with the training and the awareness of implicit bias. In other words, somehow you have to desire to correct your behaviors. Otherwise, you can feel defensive and it can kind of backfire or simply not work. I think the goal of this training is that when we walk into a patient's room, we really try to take the patient's perspective and we try to individualize people and see them as unique individuals rather than applying heuristics based on some characteristics that we are assigning to them based on their skin color, the shape of their eyes, whatever cues we're receiving from them when we walk in the room. So that I think is the goal. The issue is how much implicit bias can actually affect our explicit behaviors. So this was a meta-analysis published in 2019 that took data from over almost 500 studies. And what they found in general is when we do these studies that attempt to detect and change implicit biases and behaviors, that change is possible with interventions, but they tend to be rather weak changes. And also they don't necessarily translate into explicit behaviors. So this is not to say that we shouldn't do implicit bias. I just think implicit bias training, I think we should do it, but I think we should be very modest about what we expect to accomplish. I think we need a lot more conversation and research about what exactly translates into better, more equitable practice on the individual level. And then I think also we need to not put too much of our faith all in this one thing. I think it's really good in a portfolio of actions, of interventions that departments and whole institutions take. But please don't feel like, I've taken this training, I think 4 times now, and every time it feels so great. I feel like I learned so much, and then we walk out and I'm unclear as to what was accomplished. But I do think it is really good to get the perspective. And then I think we need to ask, but how are we changing our behaviors and what are the outcomes tied to that? I think the other thing is to really think about the impact of workforce diversity, because this has really concrete advantages for a diverse patient population. Just as a single study, these workforce diversity studies used to all be like, when we have racial or ethnic or other types of concordance between a healthcare provider and a patient, do people feel better? Do they feel more listened to? Do they feel more comfortable in that room? We had kind of this, how do you feel kind of metrics. And I'd say the studies these days are much more bold. They're basically like, was there a morbidity or mortality difference if we have racial concordance? And there are a number of studies that support this. So this is a study on looking at 1.8 million hospital births that detected improved outcome in mortality for Black infants if there was newborn physician racial concordance. And they found that manifests more during challenging births. And in hospitals that deliver more Black babies. And I really took note of that. It manifests more during challenging births, because if you think of, again, our environment where when you have a complex, high acuity situation where you have to make decisions quickly, we tend to fall back on our heuristics because we're under so much pressure that we don't have time to be really mindful about our potential biases that might be playing out. And so I see that here as well. When a birth is challenging, when it's high stress, you can imagine that our implicit biases may play more of a role. This is another famous study done by a group in Oakland that went to Black barbershops, recruited young men to come to a primary care clinic where they were randomized to a Black doctor or a white doctor, so a racially concordant doctor or a not racially concordant doctor. And they found that a whole host of things changed if you had a racially concordant doctor, including receiving blood pressure and BMI measurements, agreeing to have kind of core, preventive health screening and accept the flu shot. And they actually extrapolated out and found that if this were applied across the population, this would actually go very far in reducing this really tenacious Black-white gap we have in cardiovascular mortality. So I think increasingly we're really appreciating that, of course we can't get matchy-matchy. I don't think we'll get to the point where I can be like, I would like a 5'2" Asian female doctor to be my primary care doctor. But I do think that we appreciate, as we diversify our workforce, the chances that we can just provide better care for a very diverse patient population will increase. This is a long-term thing. It's not like everybody's going to go back and just like all of a sudden, train up a whole bunch of doctors and nurses to be really racially concordant. But I think as we do the short-term things in our own practices, in our workforces, to have one piece of you that is really thinking long-term. It's because of data like this that I will never say no to an ask to go to like an elementary school or a high school or a college to sort of talk about, what our future workforce looks like if we can put in that time and invest in what medical care will be in 20, 30, 40 years after we're gone. I think that investment is one that will pay off for all our patients. We just may not see it. Again, a nod to structural factors. I think so many of these are invisible to us. They were invisible to me, I think, before my research center decided to be very structured about the way that we look for ways in which inequity creeps in. And we thought, let's take every domain over which we have influence, and we're going to march through and think comprehensively about how we can reinforce equity and what kinds of inequities might be there invisibly. And some of these things we literally walk by every day. One for me was the vendors we use for lunch. I mean, just this small thing, but it's like, did we ever look at who we were giving our business to in the community? Could we look purposefully for minority-owned businesses? So this small piece of income that we have in our power, and we don't have a lot of lunches, but we have a small budget for events, annual events, our lunches, and we decided to shift that portfolio a little bit so that we could really give back intentionally to the community. And we had been so thoughtful, and that wasn't part of what we did. So I think everything you do, of course, our core clinical operations, our education training, our research, all those things, but I think also ways in which even these little things that you've never thought about can contribute towards your equity mission. And some things are actually much more obvious. It's just that we don't think about them. I mean, I think almost every hospital I've been in and every medical school somewhere has the wall of old white men. And it's, this is the famous one in a Harvard lecture hall, but I think, what are the cues? They don't have to be this obvious, but what are the cues when you walk in that place is not run by people like you, is not for people like you, is not built for people like you? I think we often have these subtle and not so subtle cues. What I would love for us to do is actually take some of our patients, a diverse group of patients, and just walk through on a regular basis our facilities. I think often we think about it in terms of disability and accessibility. I think we need to do those kind of investigations and just bring a really curious mind to what feels unwelcoming from the minute you come to triage, and there are cues there already that this place is not made for you. So the structural factors that really influence, we're just agents in these hospitals. How can we change some of those things? And then finally, targets and measurement. We can't fix what we don't measure. And when we're talking about clinical things that need to be fixed, we're very comfortable talking about metrics. I mean, if I get a patient with a potential stroke to head CT 2 minutes too late, I find out about it almost the next day because we have so many metrics tied to our progress in acute stroke care. And I think what we need to do when it comes to building cultures and practices of equity is to be curious all the time. We need to capture data on diverse populations. I would love it with whenever possible, we disaggregate data because groups are not monolithic. There's a ton of heterogeneity hiding in the other category. I'm often in the other category. Doesn't feel good. We want to ensure accurate data capture. So often, for example, we've heard before about how gender is not captured at all for a big chunk of our population. And often race and ethnicity are not captured at all, or when they are, it was the determination of the person filling out the registration form and not actually the patient themselves. And then we need to look for differential outcomes across all the things that we do. I think I more often dwell on these individual case studies about an inequitable outcome on a patient because it's reviewed in, say, a CQI or an M&M process, but I don't often ask my department for aggregate data to show if those things are sustained patterns across our practice, and then to have open conversations about how we actually move on those metrics so that over the course of the next year, 3 years, and 5 years, we know for sure based on the data, our practice is getting more equitable. I think we assume that we are evolving in that way naturally, but we don't have enough curiosity and concrete data to prove those things. And then of course, as previous speakers have said, those outcomes have to be the one that matter to the populations themselves. I may get fixated on time to CT. People want to know that they can, function, that they can be whole again, that they can return to their communities and be productive or enjoy life the way that they have it defined. And so we continuously have to center the populations that we claim to care about. I would also say we don't just measure in a void. We need to be as structured, as systematic, as iterative as we are, again, with our clinical care processes. And I won't linger on that. So just a final reminder, as we do all of this, there is a patient at the center of this conversation. There are patients, and we just return again and again to what is of value to the patients who come through our ER. And if we don't engage them and build the kind of bridges that the speakers earlier today have talked about, we will never know. We will be guessing from things that we have read. And so I think hospitals, healthcare system departments need to do a lot more work over the long term to engage those patients and bring them to the center of this, not to the periphery. And just to drive home that point, our orientation to all the work around equity is not one to be sort of dictated from the ivory tower. It is really like a humble recognition that what we do for our patients has to do with our ultimate outcome, which is to provide good healthcare and improve the health of our population. It has nothing to do with pitying one group, having sympathy for this group. It really is we all rise because our liberation, our thriving is bound up with each other. And that's the approach that we have, that we work together toward this common goal. I appreciate your attention, and I will stop there for questions.
Amazing. Dr. Chu, thank you so much. It's really crazy to think about how much our cultural practice environments impact our patient care. So thank you for bringing so much of this to the bedside and sort of highlighting some of our practice patterns. The first question was actually accidentally moved from the Q&A over, so I'm going to ask it directly to you. It actually comes from our clinical department head, Dr. Neil Collins. So he was asking, as a medical leader responsible for reviewing patient complaints in the Calgary zone, racism is mentioned not infrequently by patients for perceived ill treatment by healthcare workers. They rarely mention overt racism, but rather a suspicion that their poor experience was caused by racism. Healthcare workers are usually amazed to hear that they were accused of racism and vehemently deny it. Any advice in responding to these complaints?
Yeah, we know racism is there, and we know implicit bias is there. And yet it is so hard when directly confronted with the idea that a patient felt that from us, that I think our first response is to be extremely defensive. And I have had this happen to me too. And my response is like, all I do is talk about equity. They must be mistaken, but I've also been the target of racism. And I will say, it is so rarely overt, so I think we all think that as long as I kind of watch my tongue and I don't do anything overt, I'm not being racist. But I am very attuned to subtle differences in behavior. I'll see somebody speak to my colleague or a friend like this, and then they speak very differently to me. And it's a sustained difference. And then I see somebody else of a similar ethnicity come and they're treated the same way. You just kind of quietly notice. And I think for patients, when you're in such a vulnerable position, you come into an institution where there's a long history and real, live, ongoing, documented inequities happening all the time. So you are very attuned to the possibility. I think you pick up on these cues. And I really think those experiences, it's like when you have been marginalized your entire life, you recognize them. And I think either we don't believe that these things can be implicit, or we have to admit that sometimes we are implicitly doing these things. So I think, just like any, it's like whenever you get the notice of a bad case or a complaint, who doesn't feel defensive? The first thing you want to do is kind of throw things at the wall. I think the way to a productive conversation is to let the person who gave that feedback know that they have tremendous value, if that's possible. I don't know if it's totally anonymous and avoid if there's any way, but I actually think, those patients who took the time to relate that back to us, they're a tremendous resource. Just in the way that when employees leave, that's a tremendous resource and an opportunity for an institution to do better. So I think engaging patients who are open about experiences they thought were racist, and just an incredible experience. And then I think for providers, just creating a framework in which we understand that it is, while I don't want to say normal in a way that is like accepting, I mean, we are all racist. We are all have these biases, we're all ableist. We're all, we all have a strong affinity to people like us across a number of characteristics, and it makes us behave, in different ways towards people we perceive as being unlike us. So I think just coming from the frame where we are all very open, including leadership, about times when they have, been racist. I would say it that boldly. It's like, I had a patient, and I guess this isn't like me being like really vulnerable of my own, but like, we had rounds, and I asked the outgoing team what the teaching point was for that day. And the resident or medical student said, well, we talked about this phenomenon of like kind of the Hispanic hysterical patient. They talked about it as like, that's a real entity. And we had to have like such a hard conversation about how that was such a stereotype, that it was incredibly racist, and why that keeps us from giving systematically good care and taking patients seriously. And I think it is real and it is live. And I think it's so uncomfortable, but the way we make those conversations comfortable is that we just push through, until that language, that frame, that discussion is just part of how we do rounds and how we teach our learners. So thank you for that question.
We actually have a question from the live audience. I know it's hard to sort of get some interaction when it's a panelist view. So we've got a question from Dr. Aaron Johnson. So I'll actually turn it over to him to ask you directly.
Actually, I don't think it's from me, Farine. Sorry about that if I accidentally raised my hand.
Oh, no problem. Well, I do have a question from our academic department head, so Dr. Eddie Lang. So he was asking, so watching obviously US TV for the last month, or for the last few months, it seems that other than Dr. Sanjay Gupta and Dr. Fauci, that ED physicians are very much at the forefront of advocacy in the fight against COVID misinformation. Any reflections on why this has happened, and should advocacy be part of our education professional development curriculum?
Yeah, it's interesting. When the pandemic hit, Oregon happened to be, I think we had one of the very first community acquired cases in the United States. And it was at my kid's school. It was the custodian at my kid's school. And so I got this call. I can't remember if it was specifically around there, or maybe just because it was that we were so close to Washington where the very first case was, but I got a call from a CNN producer, and they were like, can you come on TV tomorrow, Tuesday, Thursday, and Friday? And I was like, which one? And they were like, all of them, because they're basically like, it's hitting the ERs, and we want ER doctors. And none of us had really done any TV before. And I was like, and everybody was getting requests, and so I think, a lot of it was we were the canary in the coal mine. We were seeing these patients come in, and we had to figure out what to do with undifferentiated, influenza-like illness, and really figure out what was the symptomatology complex. How are we protecting ourselves? And then we were like, we don't have enough PPE, and we don't have, good triage criteria, and all these things. So it was a lesson in a lot of things, but what we realized with a shock was that none of us had had training in this before, and so every day we would get a mountain of data. And I think that, I'm in lots of networks where we're all pinging each other all the time saying, how are we framing this up? It's like, there is a way to have a conversation about the J&J vaccine and its performance and whether you should want one vaccine over the other. It is incredibly hard to unpack that conversation in what is usually a 2-minute to 3-minute segment on TV, when the host may ask the question in a bunch of weird ways and throw in some other things. And so, we did a lot of strategizing and learning on the fly, and many, many mistakes were made. And I will say the conversation right now is, how do we build curricula and prepare our future healthcare providers to be good messengers? Not just good messengers of important health information, because there's kind of a stable curriculum around general health communication. It's like every pediatrician has to be able to talk about car seats and helmets and vaccines, and that's fairly stable and not so like time pressured. But when we have an emerging threat like this one, where there's so much unknown, how do we message not just information as it comes out, but how do we message the frame and the meta information? For example, the concept that a scientist might think differently in October than he did in March about, I'll correct myself there, about face masks, or about non-pharmacologic interventions, because we knew a ton more about, and we had to be nimble with that information, but people saw that as scientists being unreliable or changing their minds. We actually didn't have we operate in such a black box so often that we had to kind of teach people how the scientific process happens. And that in the moment was very hard to do and has continued to be hard to do. So I actually think after this pandemic, there will be an explosion of efforts around good health communication, like evidence-based health communication, and how we train up the entire healthcare workforce systematically as they come through our training programs. I have a proposal for such a program at my own university that I put in because I was just like, I don't need to run this, but somebody does, because this should be a standard part of our training, not just for ER docs, but really for everybody, because they have a role in this. Thanks for that question.
And this sort of links into Dr. Ian Wishart's next question. So what should we do to promote, support, mandate ER healthcare providers to work, volunteer, mentor, et cetera, with marginalized populations in the community, First Nation reserves, et cetera, so that we don't just take implicit bias courses, but live in experience with the populations we care for? And thank you for your valuable presentation.
Thank you for that question. It's so awesome. And I love the intent and thoughtfulness behind that question, because I do think too often we're like, it's important to say, what should we do in the moment? And there's a lot to be said around what we do for patients in the moment when we know that they have, historical and ongoing trauma from the type of care they receive in our healthcare settings at our own hands sometimes. But I also just love the idea of, we have to build more bridges and ramps between the communities and our healthcare centers. And I think a huge part of that is mentorship. And I think when we talk about involvement of busy people in anything like this, I think it has to be incentivized, normative, and well-resourced, so that you don't have to go so out of your way. And so we're kind of working on this right now in my own research center and department. But it's like, we're thinking of what are stable funding streams, for these kind of programs, so that minority students and pre-meds can come in and actually, be paid, come with a stipend, because there are actually a lot of those programs out there, but we just don't take advantage of them. So, and then how do we make ourselves known to these programs so that they can connect us, and there can be kind of a steady pipeline once we build relationships. And then how do we incentivize that? And we're talking to our chair about how do we build in to the reward system, and build into the promotion and tenure process the idea that these kind of mentorship roles are highly valued, so they should be explicitly valued in our promotion and tenure criteria. So people feel that is like something as worth doing as, say, writing this paper or applying for this grant. But I think we need to, and then we need to communicate that this is a highly valued thing, and just make it such a part of the environment that it's like, who are you mentoring this year? I think there's that culturally normative part of it that often doesn't happen. So I think we need to talk about it, brag about it, ask people who their mentee is, until people kind of feel like, I'm missing out if I'm not doing that. You don't want to feel like an outlier. You don't want to feel like you are like a bold person in front for doing this. You want to feel like it's just a natural part of what I do. And that's where you just really need cultural change to kind of sustain engagement in some of these areas. But I think, it's the kind of thing that feeds on itself, because as we do these mentoring programs, we change the face of our workforce, we change who becomes senior and becomes mentor, those relationships start feeling more natural. It can feed upon itself, but I think upfront in the first decade of such a program, you really need to work on making it easy, normative, you know, and really admired and valued in your health system.
And this again sort of connects to one of the anonymous questions that I received in regards to, you know, when you were talking about the greater picture of inequity and barriers in our patient care and what they face, and sort of how to increase representation of diversity within our healthcare workers. The question was, how do we as frontline workers help to invest in younger learners to motivate them to join the ranks without expecting them to sort of shoulder the burden of EDI and themselves?
Yeah, I really love that question. You know, and I do think that, I mean, there's two parts that shoulder the burden. I think when you start, like the hardest thing is starting, right? I mean, when you start out and you don't have a very diverse body, the few people that are there are so overtaxed, even though they're likely to be the most effective in this at work. And so I think, you know, I think it takes a lot of very intentional work and planning to try to figure out how we can take the existing minoritized physicians, nurses, faculty that we have, and try to provide as many resources so that anything they do towards these efforts can be magnified tenfold by the rest of us, you know, who are not as minoritized and can take on the brunt of that. And so, you know, and that can play out so differently just depending on who your faculty are and the way they want it to play out, you know. So I've been in groups where it's like the minoritized faculty are like, I'm good being the face of things. So like, I want to show up and do the things so that people can see this is what a Black doctor looks like, you know. But they're like, but can you guys take care of all the admin? And we're like, yes, we will set up the talk, do the Zoom, you know, basically move everything around you. All you have to do is show up on the day. And sometimes that's it. Sometimes people are like, I am tired of being the one up front all the time, but I'm happy to give you content that I have already created, and you guys can be the emissaries. Can somebody else please stand up there and present this? And it's like, yes, we can do that. You've built an incredible thing. We'll do the formatting and we'll do the presentation, and let us take that burden off you. And I think it just plays out differently for every person. You know, minoritized people are not a monolith, and I think, you know, it's just a conversation about how to be respectful. But I think, yeah, and then how do we really change expectations of, you know, potential future workforce? I think we need to go as upstream as possible. You know, it's like, I will always say yes preferentially to the upstream thing, because, you know, by the time children are 5 or 6 years old, they already have preconceived notions for what they can accomplish and what roles are right for them. So, you know, it's like, I try to always say yes to medical students, but even more so for college students, even more so for high school students. And you know, an opportunity literally at a nursery school or an elementary school is something that I would never turn down. When we can go upstream and change people's frames, and then really contribute to programs that allow people to have sustained engagement and success in their scholarship over the course of their education, but as early as possible, that's where we have the highest impact. And again, we may not see that back, but we have to do that work now so that we have an actual pathway into healthcare, rather than trying to, I think what we do is we kind of wait until people are applying to med school, and then we have all these programs, you know, to try to make sure they succeed. Like, that is necessary, but it's like, it's doing the most with this little bit of, you know, that we have over here, instead of really opening up pathways early on, where we can just really have a huge potential workforce. That's really where, you know, we get bang for our buck.
So this next question comes from Dr. Haley Cochran. She obviously thanks you for your incredible lecture, but unfortunately in medicine, and especially in emergency medicine, she was asking if there are significant underlying financial motivations for our actions. So in Calgary, we're fee for service. So of course the RVU, patients per hour, high cost procedures. Are you aware of any evidence for sort of financially motivated interventions to help tackle DEI?
Yeah, it's a great question. I have heard of some, and I don't know how effective they are, because I just don't know how well it translates. But, you know, particularly at least in it seems to be in the United States that a lot of Catholic or religious run hospitals, we have all these, do you guys have this? We have all these like religious run hospitals, there's like a history to that. And so some of our biggest hospital systems are basically like Christian hospitals. And they often have a built-in financial incentive for progress on diversity, equity, and inclusion. There's enough of a pot of money that actually people really scramble to fulfill these things. And they're distributed in different ways. Often they're given to like leaders in the hospital over a certain domain, over say nursing or over this division or unit. There's like a built-in annual incentive, and they can use that money however they want for some programs. So sometimes they will say an individual chair might say, we're going to look at these core outcomes by race and ethnicity, and they should be equitable. And if you do, you get a little added bonus this year. But it's not so tightly tied. I don't think it's so tightly tied to like your actual like sustained, I haven't heard of a program that's like really on the level of like every time you get your paycheck, or like as often as RVUs are factored into your pay, there's this element of DEI. That would be a fascinating, organizational intervention. I haven't heard it like that, but I've heard more of like a discrete once a year kind of payout for evidence that you provided equitable care or improved something in your department to ensure that equitable care happens across the system. So, but the kind of thing that you mentioned, I would be really fascinated if there were kind of like an RVU calculator. This is a race adjusted calculator I would approve of. How about like a equitable care adjusted calculator for your RVUs? Would be super fascinating. I would love to know whether people could be incentivized on that level, and it would be I think that'd be a really remarkable study to look at.
We're moving to a new online system in a few months. And so I think it will be really interesting to take a lot of what you're talking about in this discussion and see what we can do with like our electronic medical records and sort of see if we can get some of this research going. And on that specific topic of research, when doing research projects, are there any techniques you recommend to identify and make accommodations for racial bias when coming up with study designs?
Well, yes. That is a long talk that I can give. I actually think what we've decided in our research center is that having a health equity approach to research study design is relevant to every study, not just health disparity study. So we used to be really conscious of all the race variables and the ethnicity variables and the kind of construct of study and the power calculation around race and ethnicity only when that was the explicit research question, So you'd have this health disparity study that was just beautifully designed, had kind of like a team that could really support this. And we were like, but if inequity is in everything, why are we doing this only for the explicitly inequitable studies? And so now we're in the middle of still refining this framework, but the framework we're trying to take is that for all studies, from the minute you come up with the study and put together the study team, we should have a health equity approach. So I often get these little messages that are like, hey, we're doing this study and we want to make sure we're handling race correctly. What is the best way to handle that? And I'll be like, you should ask the people of color who are on your study team. And there's just silence usually. And what we're trying to do is really be like, from the minute you pull together your study team, you should be asking, what is the health equity approach? And part of that is having a diverse study team. It really is, so we're trying to get people to think, okay, so once you have your diverse study team, honestly, everything else is easier than it was before, because that diverse study team tends to have a much more equity-oriented approach to the study design. And I think there's so many things in terms of how we define race and ethnicity. And I'll say, I just came off NIH study section. I'm so aware right now about how in the same grant, people actually have no idea what they're talking about when it comes to race and ethnicity. So what you'll read is, they seem to be talking about it like it's a biological or genetic or ancestral issue for that health issue. And then they're over here talking about it as a social construct that impacts people's environments and experiences with healthcare. And then they're talking about it over here and talking about like, implicit biases and skin tone and other, it's like, it's a hot mess. And so I think part of it is like upfront saying, how are we approaching race with respect to this disease process, and the outcomes that we're interested in? What do we think the mechanism is for the relationship between race and this disease, or, and how it would affect the intervention or whatever phenomena you're studying. And I think having that clear understanding up front will actually inform the rest of it. And then I think the other big thing, there's a lot I could actually, I actually have an hour-long talk about what it means to have a health equity approach to research. But I think like one of the big things we hardly ever do is really consider careful measurement of race and ethnicity, and also remember that some of the categories we use are so insensitive. I mean, I was reading a study where Indigenous peoples, Pacific Islanders, and Asians were all in one category together. We were like all the leftover people, and they just put them all together. And I was like, but that doesn't make sense. It's like there's so much, that's why I had that little asterisk. It's like, nobody has thought through race in this study if you're putting those groups together, because the forces that affect those groups with relation to that disease they were reporting out are so different. And so they were just like, I mean, that variable was meaningless, the way they had categorized the race variable. And I also think we often treat, we treat like whole categories like Black Americans, we'll say, as if that's just a monolith, and what you don't realize is there's as much heterogeneity within that group as there is between groups. So look, creating enough of a sample that you're able to detect within group heterogeneity as well as between group heterogeneity actually reveals so much about how you need to approach communities with, say, information about a vaccine. Because we have this impression that, I mean, you'll read it in the news all the time. Black people need to hear this about the vaccine. It's like, well, I mean, who did you ask and who was in that group? And are you aware that Black Americans is a tremendously diverse group of people, as are Asian Americans, and Pacific Islanders, tremendous heterogeneity, Indigenous groups. How many nations are represented and clumped together in that Indigenous category? Are you aware that there are profound differences, in how you need to execute anything with relation to a disease? So, I mean, those are just a few things, but I think, there are, the WHO has like, a really nice framework for considering health equity. And I think, again, I think those really should be applied to every single study that's out there, at least to some extent.
Kind of coming back to a bit more of a clinical related topic. There was an anonymous sort of comment a colleague wanted to make that people are actually financially disincentivized to see patients who are from diverse backgrounds. So there's often language barriers, social constructs, challenges with continuity of care that make the interactions more time consuming. And then to add on top of that, if there's a massive language barrier, sort of finding our, the video and ability to be able to.
Where is it? Yes.
Exactly. And so there's sort of this conversation or this thought about, potentially having billing codes that actually reflect the complexity of the patient presentations, and thinking a little bit about how that would impact your EDI patients. Do you have any comments on that or any suggestions with our department sort of in moving those sorts of ideas and things forward?
Yeah, I mean, I first have to totally agree with you that this is like the definition of lip service, right? It's like we say we want everyone to get equitable care. And that's like, so head this direction on the highway. And then you realize you are actually walking headfirst into a 5-lane highway with all other forces headed in the other direction. And they're like, but keep on going that way. And the 5-lane highway is full of things like, but also see more patients. And there's going to be one video for a translator and you can never find it ever, or it's out of batteries or not connecting to the network, or, we give you no financial incentive. It's like the forces just keep on coming. And I think that's part of that like whole system approach to equity. If we believe in equity, like we really believe in its endpoint, which is that patients will get better care and we will in aggregate have better patient outcomes. We will have fewer costs of care because we will have have less adverse outcomes. We subject ourselves to much less liability because we're not providing great care. If we're really all in on the idea of equity, we have to start turning around those lanes, And so it's like, what would make language services easy and a pleasure to use? And one thing we did in our ER is like, we just got a bunch of them, it's like these things on these iPads on wheels, and there are people who just make sure that they are always connected, and we increase the number of language services available. And it's like, that has to be easy. It is now finally easier for me to roll that thing in than to try to work with the family member, because they're so good and I can do a much more efficient interview than trying to work with a family member who is not used to the medical translation. But it's like, well, I think we just need to start flipping those lanes around one by one and figuring out what those barriers are, down to the financial incentive. I completely agree with you. But this is like one of those things where we our statements of intent sometimes are not fulfilled in our actions. And I think we need to have that very hard conversation that you just brought up, which is like, why are you making it so hard and such a disincentive for me to do this? And again, it goes back to the previous question, is like, how can I make it financially relevant for you to actually try to address the implicit biases and the practice patterns that work against patients who are hard of hearing, who have disabilities, who speak a different language, who have had experiences of, I mean, when I've had a patient who has had very, very bad experiences with healthcare trust, they're transgender and they were totally traumatized by somebody in my very department earlier, that takes time to undo. Like, if I'm going to have a good rapport with that patient, I better be ready to sit down and be like, please tell me what happened. And then, can I have a talk with you about how we can make sure that doesn't happen again? We have many sickle cell patients who had terrible experiences because they came in and were explicitly told they were drug-seeking patients. Every time they come, they have this look on their face like, are you the doctor who's going to accuse me of drug seeking, or are you going to be one who understands that I would not be here except for my pain? And it's like, you have to take time. So what is the incentive for that? And I think if it needs to be a financial incentive, then I think we need to do that. I mean, we know in healthcare that financial incentives are not often coupled with what we consider to be compassionate care. I think for the time being, we have to probably align incentives by individual departments. But I do think building in complexity of care things, building in equitable care, anti-racist care. I mean, imagine if those were billing codes in some way, probably makes a lot of sense. But remember what I said about implicit bias training works if it's aligned with motives. We have to figure out how to align those motives. And one is clearly financial.
Actually, one of the suggestions from one of our docs, Dr. Kathleen Dorrington, was the idea of eliminating the terms like non-English speaking or similar statements in the triage notes, because it makes it very easy for people to selectively skip over some patients who potentially might be more complicated, end up sort of having a longer wait in the department. So that's a really interesting thought, to sort of see a simple sort of change we can make in our own department, just to eliminate some of the obvious first biases.
And actually, that makes me think of something else that comes up in research and also in clinical practice, which is what we define as normal, says so much. And whenever you say non-whatever, I mean, when I read a research project, a research paper, and it says white patients or non-white patients, it's like, you're basically saying, in not so many words, there is a norm here. And anything off the norm is kind of troublesome. And I think just in saying non-something, you signal to the provider, oh, it's non-normal, Q will take longer, more difficult, don't want to go there. I'm going to subconsciously just come up with a reason to prioritize this patient over here. So I agree, like every word has meaning.
This next question is from Dr. Laura Cook. So Dr. Chu, thank you for a wonderful talk. You are a superstar. Do you have advice on how to approach colleagues on these issues who immediately get their hackles up when the question of bias and privilege are raised, even from an educational vantage point in clinical care? I'm torn between trying to sit down for a fireside chat with these very resistant individuals, or focus on the people who actually want to engage in the discussion and leave the hostile skeptic to another day. As a person in a privileged position in leadership, I feel some duty to engage with the late adopters, but I'm at loss for how to do it when they just don't get it. What is your strategy?
So that is a question that's near and dear to my heart. And I will share, when I first started giving these talks, I was like a bull in a china shop. I just stomped right in, and that's not good. And I think when, especially when I know my audience, like this is a kind of a forum where I felt like people were really primed to hear the conversation and came willing to the table. But there are some forums where people will put me on the agenda for for this kind of topics that I like to talk about in the middle of, like, say, a pure clinical day with an audience that you wouldn't expect to be super friendly and is not primed to have this conversation. And I have had talks where when I started talking about racism or sexism really bluntly, I've had people walk out. I've actually had many, many talks where people walked out. And one time, actually, a friend in the audience stood up and walked out. He was so upset with me. And I had to go and have a one-on-one conversation. And I think I totally changed. First, I was defensive about that. Like, well, if they can't handle it, then that's fine. But then I realized that this is hard for everybody. I mean, there are definitely times where I raise my hand and I want to say something about inequity, and I have kind of this nervous butterflies in my stomach because I'm not sure whether I'm going to say it right, accidentally offend somebody, the right language. And so I do such a big preamble now when I'm going to an uninitiated audience or just like a undifferentiated audience. And I just sort of talk about how we all have biases, and I will be really transparent about my own, and how I take the implicit bias test every year in April, every year since residency. And it still shows that I have some very persisting biases, even though I talk about biases all the time. And I don't think I can ever erase them. I just know that I have them. Some of them shrunk over time, but some of them are still there every year. And, you cannot game that. I don't know if you've taken it. I'm like, I'm going to win this time. And like, I cannot win over this thing because I wanted to just say, you have no biases. And with my best intent, you're clicking fast and they show themselves. And so I try to be really transparent about my own biases. I try to be really transparent that I am sexist and I am racist. And it is the way that our brains are wired. So it's not like you're diseased or your parents didn't raise you right. It's that this is what we all live with, biased frames with which we walk through our world. But we have an opportunity to try to build a better world in which it is hard for them to manifest in a way that is harmful. So that's one thing. And the other thing is, like, I do think your energies are best spent on the movable middle. I'm spending a lot of time thinking about this because it comes up in like vaccine uptake. It's like there is going to be fixed extremes where you could expend a ton of energy to make like this much effort, or you could take that energy and put it in the movable middle, people who are receptive but just aren't quite there, who are at least pre-contemplation with their change, and it's like you can move things there comfortably, and we probably should, for the most part, spend time there. But I will tell you that if you are consistent, patient, positive, thank people for coming to the discussion, even if they don't say anything for like the first 10 sessions. If you are like that and you stay data focused and driven and focused on our ultimate outcome, which is better patient care, there are people who come to the table. And I have somebody in my inbox right now who over a long time went from being defensive, arms crossed, didn't want to talk to me, didn't seem to like me, to actually thanking me for work and asking how they can be more a part of it. And I would have put a lot of money down that person was a fixed outlier. So I think you can't predict who will ultimately get there, and the decisional balance can take time. And so I think some people, you just keep on sending a signal out, and they just need time to get there. So don't lose hope, because I think being that person who is always willing to talk to anybody and find some common ground, that's rare. And so I think you just project that you're not judgmental, you empathize with different paths to this work, and you're always ready to support people in their journey. I think it can be really powerful. I think people often feel boxed out and then they just dig their heels in. But if there's always like, you're so welcome here, say a couple awkward things, we all do, I think that sends a really good message.
I like the movable middle. I think that's a very powerful sort of statement to think about. And I think we'll take maybe one, maybe two last questions. So Dr. Ian Wishart was asking, what do you think of some of the EDI lessons the United States may learn? And then of course us, from the significant disparity in mortality from COVID compared to other countries.
You hope that we both learn in the moment and that it kind of feeds your ongoing actions, and then that we make a huge investment going forward to address all the underpinnings of those inequities. But I despair a little bit, I'll have to say, because right now, if you look at the emerging data on our vaccine distribution, it is simply reaccreting the inequities in every single resource and outcome we've had so far. So it's like what we saw in testing, what we saw in treatment, in triage, in disease prevalence and disease severity, death, it's all being echoed in our vaccine data right now. And a lot of it is, you know, our states are struggling to put in place algorithms that could reverse it. That's kind of what I'm doing with my time, is just being like, oh, this state is trying this really interesting thing. This state is trying. We have so many states that you can see all their different experiments, and nobody has metrics yet to see if they're improving. I'm trying to figure out a project on the side with IBM, because they have this incredible ability to take real-time data on a bunch of state policies and actually tie them to some of their monthly surveys they do across households in the United States when it comes to things related to COVID. So hopefully we'll be able to learn what are kind of effective strategies. But I think much deeper than that, what we really need to do now and going forward is just consider the way that our entire health system and public health model is broken here. You know, I mean, where we've invested resources is completely the opposite compared to what we needed to do. And it's really like our community health centers, our public health infrastructure is where the power should have been, because that's what could carry information and resources into our communities, particularly our communities of color. And so that completely failed, because we've spent many, many decades setting it up to fail in this moment. So there needs to be a reckoning, there needs to be change in policies. And actually, you know, there's lots of talk about how there should be a health equity person in every single department, not just health departments, but, you know, our transportation policy, our environmental policy, our education policy, our housing policy, all those have such a huge influence on health equity that they all should have a health equity office, or at least officer, so they can understand the health implications of what seem to be simple and straightforward and, you know, kind of data and financially driven decisions on a very big level. So these are conversations. I don't know if they'll be translated, but this is actually like at least our hope for the United States. And we'll see if we learn that. I think there was a second part of the question that I forgot.
I think you'd answered the majority of the.
Did I answer it? Okay.
That sort of leads me to, if you had any final words or thoughts you sort of wanted to leave us with before we let you go.
I guess I just hope that everybody takes a piece of this for their own ownership. You know, it's like it is overwhelming to consider all the ways that inequity creeps in, and yet we know that one person can make a difference, a profound difference. And I heard that thread through our previous speakers as well. And I think everyone can take one thing and make it their specialty thing, and it can be so simple. You know, it's like I was very moved. I worked a lot on face masks and personal protective equipment, and I was very moved by homebound elderly people who wrote to me and said, "How can I can sew. It's like literally the one thing I can do. I can sew. Can you give me some specs for face masks? I can sew, and I can drop them off at hospitals or at health centers that I read are lacking them." And it's like everyone has a role in equity, in health equity. And I think just hopefully you can take a piece of it. It can be small, it can be big, and just move forward with it in whatever domain you have influence over. And if you can do that, then I think collectively we could really accomplish something amazing.
Thank you again so much for your time, Dr. Chu, and for such an inspirational talk and reminding us of sort of the greater picture of inequity and the barriers to care that our patients face, and for some of the more practical sort of applications of how each of us in all of our diverse roles, whether it's leadership, whether it's at the bedside, whether it's outside of the hospital, sort of thinking about the impacts we can have with elementary school students and high school students, and sort of the whole gamut of how we can each impact and sort of improve the care of our diverse population. I truly have no idea how you managed to make the time for our talk with everything you do, but thank you again so much for your time.
Truly, thank you for having me. And just, again, it was such an honor to hear the other speakers for this event. I learned so much, so really appreciate it.
I will now pass it on as we again jump over to our EDI working group here in Calgary. Thank you to Dr. McLeod and Dr. Putty, who were initially thrown into the lecture when we had a little tech glitch, and appreciate their emerge doc style of just sort of being ready when they weren't expected to be. But I'm going to turn it over to them.
Thanks so much, Farine. And I just wanted to thank the organizing committee for such a wonderful morning, as well as thank you to all the wonderful speakers. You've literally been inspired. inspiring and have inspired me to kind of continue with the work that myself and the committee has started. And I'm just going
You muted, Jen.
Oh, how's that? Sorry. What I wanted to do today is actually, Kelsey and I, we're just going to introduce to the department at large, essentially for our Department of Emergency Medicine in Calgary, the Anti-Racism, Diversity, Equity, and Inclusion Working Group. Our first steps for our working group were to make a commitment to meaningful change to our culture. Anti-racism, diversity, equity, and inclusion is a priority for our department. The idea of this working group was born in June of 2020 when CAPE, the Canadian Association of Emergency Physicians, released an official statement condemning the acts of violence and underlying systemic racism that disproportionately affect Black, Indigenous, people of color. CAPE challenged the emergency departments in Canada to reflect on the ways in which our own practices contribute to discrimination and to advocate for change. From this statement, I was inspired to reach out to our leadership to see if and how the Department of Emergency Medicine plans to address these issues. And here I am with incredible members of our department, and we have a working group put together. The current members include Kelsey McLeod, who's here with me today, Patty Lee, Tayo Dawadu, Chris Bond, Sarah McPherson, Tash Wright, Mandeep Shran, Huma Ali, Fareen Zaver, Ian Wishart, Claire Acton, Kelsey Reagan, and myself. Our accomplishments in 2020 include developing a department anti-racism statement. We've developed a bystander intervention training. We've advocated for appropriate PPE for patients and staff, and supported the initial development of equity rounds, such as our rounds in October 2020, which was responding to microaggressions in medicine. The working group has also liaised with the residency training programs, and we will be a representative on the residency EDI group. Current projects that some of our members are working on are creating an anti-racism curriculum for the residency programs, developing SIM-based culturally competent care, and liaising with the Calgary Black Chambers for potential future collaborations and mentoring. In 2021, we completed implicit bias training to all the FRCP CARMS committee members. We will also be leading this course for the FRCP and CCFP EM residents next month. And the same course will be provided to the Physician Executive and Manpower/Hiring Committee in October of this year. We hope to create our vision and mission statements in the next month, and we'll develop a defined terms of reference. Our goal is to make meaningful change in the department. We invite each of you to reach out with any questions. We're very happy to help support any projects that fall under an EDI umbrella. Overall, I mean, this today has been just incredible morning, and I'm again further inspired to continue with this. I certainly was interested in the implicit bias kind of training talks, because we have been leading that, but there's so much more to do. Kelsey, do you have anything to add?
Yeah, I thank everyone for the great presentations and for the organization. Some of the things that jumped out to me, like if people are feeling really inspired, they are thinking, you know, starting to have a train of thought based on some of the presentations we've had. Yeah, definitely please feel free to reach out to our group. But also some of the like immediate things that come to mind were Dr. Chu was talking about interventions upstream, and one of the programs that, or one of the things that I'm working on with the collaboration with the Calgary Black Chambers is a mentorship program for Black youth. And so if there are people who feel like that might be somewhere they want to contribute, feel free to send me an email, which I will put in the chat box, and I can connect you with one of their programs. Yeah, but always happy to support additional ideas or projects that people are hoping to realize within this realm as well. So that's it.
Amazing. Well, thanks to both of you for leading the incredible work that our department is sort of supporting and moving forward. So it's been very inspiring to sort of sit on the committee and hear all of the exciting things that everyone is sort of is moving forward. On behalf of the entire Hodsman Legacy Lecture team, wanted to thank all of our incredible speakers today. A lot of them put not just their heart and soul into the presentations, but also were quite vulnerable to the group of people who attended the lecture today. So I want to thank them all for sharing their perspectives today, their thoughtful recommendations for improving our approach to caring for our diverse population in Calgary. I also really want to thank the incredible team for the Hodsman lecture. It was led by Dr. Marcy Veach, who put in an incredible amount of work. And I also want to thank the rest of the committee. So Dr. Eddie Lang, Colleen Carey, Aaron Johnston, Ashley Wilmot, Haley Cochran, Breton Hari, Bobby Johnston, and a special thanks to Jill Vadenbrand for all of our tech support and sort of managing everything in the background. So there was a ton of work done to pivot to a virtual lecture last minute and to get this amazing group of speakers together. And thank you to everyone who came and listened and was open to sort of learning about EDI. And hopefully this is just sort of a continuation of the great work that we're doing within our department. So thank you guys again so much. And then of course, there's a few additional resources up here on the screen. And please don't forget on the next slide, we've got a quick QR code and in the newsletter on Tuesday, as well as attached to the reminder to jump onto this lecture is just the evaluation so that you can get some credit for the time that you've spent. And thank you again to everybody and hope you have a great rest of your Thursday.